Welcome to our Tech Forum session, Modernizing Public Health Data Exchange, Lessons Learned and Tools for the Road Ahead. My name is Tom Deneen with Kaufman and Associates, and will be assisting with the logistical support for this Zoom session. You can ask questions by clicking the Q&A button, which is located towards the bottom part of your screen. Click on the Q&A bubble icon, and this will pull up the Q&A box, which will open to the right side of your Zoom interface. You may also use the raise hand function under reactions, and we will unmute your line to verbally ask questions during the session. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share information. If you need technical assistance during the session, click on the chat bubble icon at the bottom of your screen, and this will pull up the chat box, which will open to the right side of your Zoom interface. Please type the issue into the chat box and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Steve Posnack.
All right, thank you very much. I serve as the Deputy National Coordinator for Health IT, and it's my pleasure to welcome you to today's session. I did want to thank you for taking your time out of your busy schedules to join us in collaboration with our colleagues at CDC to learn more about the, it's hard to say increasingly important, the continuously important topic of public health data modernization. And I know many of us still have the COVID-19 pandemic top of mind as an experience and as a response. But you know, my evolution in this space is one shaped by how we responded to Ebola and Zika and a few others, COVID pandemic. And so it's just a thank you opportunity for me to all of our public health colleagues out there for all the work that you do. Sometimes it's a little bit behind the scenes. But we know in this space that you're continuing or continually operating to help us get a better sense of the threats that we face out there. And even as we meet today, you know, we're, I guess, at the cusp of the fall respiratory virus stage with a number of usual suspects in the mix, in addition to, you know, the COVID variants there as well. And so as, you know, we consider the types of threats that we face from a public health perspective, it's really important to underline the modernization aspects that are underway and increasing interoperability across our ecosystem, including the number of different community members that are part of public health response. So, you know, the burden for healthcare providers and other clinical professionals out there, as well as you know, increasing the efficiency and optimization of public health to get data and to be a bidirectional partner in helping to inform clinical care. And so the more that we can help ensure that data are exchanged more rapidly and available to support, you know, kind of daily and weekly response as well as emergency responses, all the better. And so today and over the next 2 days, during these sessions, we are aiming to provide you all with a sense of where we are currently, by presenting results of recent national surveys and evaluations of public health data exchange, an idea of progress made so far around public health for public health agencies and advancements that have been made through the data modernization initiative that our CDC colleagues are leading, a vision of where we're going, and through an overview CDC conversations with leaders from the public health and key technology space community, and then a sense of how public health fits into the broader interoperability initiatives led by ONC, including our Trusted Exchange Framework and Common Agreement Initiative, the United States Core Data for Interoperability, USCDI, and then the USCDI Plus processes as well, for which we've engaged our public health colleagues too. So with that, I don't want to stand in the way of you and all the exciting programming that we've got scheduled for you today. We thank you again for all of the work that you do on a daily basis, and we hope you can walk away from our workshop with both a sense of optimism and a real sense of forward progress from a nationwide perspective. So with that, I'll turn it back over to our MCs, and we'll proceed with the rest of the agenda. Thanks.
Great, thanks, Steve. I think we're going to move on to Jen, who's going to provide some opening remarks from CDC. Thank you.
Great, thank you so much. And thanks to our ONC colleagues for hosting this really important event and really for their strong support in partnership in the critical work that we're doing in and across public health. My name is Jen Layton. I serve as the director of a brand new office at CDC, the Office of Public Health Data, Surveillance, and Technology. This is the office at CDC charged with leading the DMI effort, as well as driving forward with our public health data strategy. It's really exciting to see the list of participants and the representation from state, local participants, as well as federal agency partners and so many others that are really critical to the work that we all know needs to happen. We've all faced and experienced the challenges in data exchange. COVID and MPOC certainly highlighted that, but I think similar to what Steve said, these are challenges that have been there for a while. And as we continue down this modernization path and leverage the funding that we've been provided to make these necessary changes, you know, I think there's a really unique point in time where we become as aligned with the health IT industry as we can to support robust, rapid, automated exchange of public health data. We've seen great progress over the last few years, and I think it's important that we highlight that to speak to the successes as well as the impact of the dedicated DMI resources. We have electronic case reporting now that prior to COVID had less than 200 facilities able to transmit electronic case reports. We now have over 28,000 healthcare facilities that are able to send electronic case reports, and we are seeing very innovative ways and approaches that jurisdictions are using electronic case reporting for multiple different public health purposes. We see the continued expansion in use of syndromic surveillance data and the more rapid exchange of vital records data, which is thanks to a lot of the work in the standards place, leveraging FHIR capabilities and whatnot. We have set forth as part of the DMI effort, a public health data strategy that lays out 4 high-level goals in very concrete milestones of what we are striving to achieve across public health to support that rapid exchange across public health jurisdictions, within public health jurisdictions, and to and from bidirectionally with our healthcare partners. I do want to emphasize, and I think critical to this discussion is the importance and the role of data standards and system standards around functionality. The importance and the benefit and the value add from leveraging the technology really will help to expand and increase our capability to ensure secure and timely exchange of data. And it's really with our colleagues at ONC and CMS and others where building and strengthening and continuing those partnerships is critical to make that happen. The work that ONC is doing around public health system certification, we're really excited to be partnering with them on that. And we did have that recommendation that also went to the advisory committee to the director at CDC that recommended we pursue public health system certification. The work and the exciting opportunity for TEFCA and healthcare data exchange is something we are actively looking at across CDC and looking forward to identifying those early use cases to promote public health data exchange. So really excited to hear of the successes throughout the conversations, what's worked, where there are challenges to help guide us in our next phase of continuing to modernize across public health in our systems. And I want to end with saying that as we continue the work on the technology front, the work in the data policy space, as well as the establishing, implementing, adopting the standards of data elements and of interoperability will continue to be critical. And so looking forward to ensuring our growing effort to incorporate that into the important work across DMI. So once again, thank you, Steve and all the ONC colleagues, and thank you for everyone who's participating, whether through a presentation or in the discussions, and look forward to the discussions forthcoming. Thank you.
Thank you, Jen. I think we're going to be moving on to our first opening plenary, and I'm going to hand it off to Vaishali Patel.
Great, thank you. So welcome to the opening plenary. Thank you all for joining. The opening plenary, as Steve described, will really focus on the current state of public health data exchange using national survey findings from physicians, hospitals, public health jurisdictions, and health information exchange organizations. And each of these perspectives, we believe, is critical to look at together to be able to shed light on where we are today, what progress we've made, as well as identifying barriers and potential solutions to continue that progress. And I, Vaishali Patel, Deputy Director of ONC's Technical Strategy and Analysis Division, I'm going to kick off the discussion by describing national survey findings from both physicians and family medicine physicians and hospitals on their engagement with public health data exchange. And then following myself, the next speaker is Elizabeth Rubrush. She serves as Senior Director for Public Health Data Modernization and Informatics at the Association of State and Territorial Health Officials, or otherwise known as ASTO. She oversees a broad range of program and policy activities related to data system and technology modernization, health information exchange, and public-private partnerships to advance state and territorial public health priorities. And Elizabeth will be describing state and territorial public health officials' perspectives on public health data exchange based on data that they've collected from these officials. And the final speaker of the plenary, last but not least, is Dr. Julia Adler-Milstein. She's on faculty at UCSF, where she is leading a newly formed division of clinical informatics and digital transformation. Her research sits at the intersection of clinical informatics and health policy, and she's focused in particular on studying the evolution of health information exchange and interoperability. Julia will be discussing the results, the most recent results, the survey just completed over the summer of a national survey of health information exchange organizations that was supported by ONC. So I'm really excited to get going. Next slide, please. So as I mentioned, I am going to be starting us off by discussing hospital and physician survey findings that shed light on public health data exchange from their perspective. Chelsea Richwine, who is an economist within our division, led the analyses that are part of this presentation. Next slide, please. So there are two data sources that we are using. One related to hospitals, which comes from a partnership that ONC has with the American Hospital Association. It's an IT supplement survey, and the data that I'll be presenting on is from the most recent survey, 2022, that consists of 2,500 hospitals and had a response rate of about 54%. I'll be describing hospitals' engagement in public health reporting, comparing findings back 1 year to 2021, so a little bit of trend data, and then also focusing on what ongoing challenges hospitals have identified that they face when reporting to public health agencies. And the findings, I'll be highlighting a number of findings, but the full set of findings, I'd encourage you to look at ONC's data brief, number 66, and the link is provided here. So for more details on that. On the physician side, we are using national data from a survey that's conducted by the American Board of Family Medicine as part of their continuous certification questionnaire. And that is a unique data source because basically the response rate is 100% because this is part of the recertification process. So we're really excited to be able to use this data source to shed light on where family medicine physicians are with regards to their engagement. And we focused findings here on immunization related exchange. So looking at both reporting data to IISs as well as accessing and viewing these data. And then looking at also physician satisfaction with their ability to access immunization information. Next slide, please. So I'm going to start with the hospital public health reporting findings. Next slide. So good news is that in 2022, nearly all hospitals were actively engaged in at least one type of public health reporting. As you can see here, about 96% of hospitals in 2022 reported that they engaged in at least one type of public health reporting electronically. And the rates are relatively high, in the high 80s and 90s for immunization registry reporting, syndromic surveillance, electronic lab reporting, and then it begins to drop off as we look at public health reporting, electronic case reporting, and clinical data registry reporting. Although there were increases in some of these from 2021 to 2022. Next slide, please. Now, the overall high rates of electronic public health reporting do vary by hospital characteristics. So on average, hospitals reported that they engaged in electronic reporting for 4 out of the 6 types of reporting that I previously presented on the previous slide. But hospitals that have fewer resources, so smaller hospitals located in rural places, critical access hospitals, independent hospitals, were reported that they had lower levels of engaging in electronic reporting compared to those hospitals that had greater resources. Next slide, please. And this also varied by state. And I know these numbers are really small, so my apologies that we don't have a map for all of these different types of public health reporting. But in 2021, so just a year prior, when we had done the data brief based on the American Hospital Association survey findings, we have reported at the state level for each of the different types of public health reporting. And there is variation at the state level, as one can imagine, with regards to engagement in electronic reporting, in addition to hospital characteristics. Next slide, please. So back to the 2022 results. So overall, we noted that, many hospitals are engaging in electronic reporting that varies by type of reporting. And we can also see here that in terms of whether the processes that are used for reporting are automated or manual, is also relatively high in terms of, particularly for immunization reporting, syndromic surveillance, electronic lab reporting. Those are largely done in fully or primarily automated manner. Whereas, it starts to drop off with electronic case reporting and is very low for hospital capacity reporting. And how we define manual is, the use of fax, paper, and just, having an individual be involved in the process The mix of automated and manual could be something like, using the EHR to extract the data, but that there has to be a person involved with the actual submission, or maybe entering information in by hand. I think what's encouraging is that, for a lot of the required reporting that's done electronically, it's also fully and primarily automated, but that there is progress to be made, particularly for those types of reporting that may not be required consistently across the board. Next slide, please. In terms of the methods used to submit data for all 6 types of reporting, EHRs are primarily used, particularly again, for those top reporting types that are required: immunization registry, syndromic surveillance, electronic lab, electronic case reporting. Again, it drops off, and there's greater portal use, flat file use for public health registry, clinical data registry, and hospital capacity reporting. Next slide, please. In terms of the barriers that hospitals reported, from their perspective, the top barriers that they reported were related to their perception that public health agencies lack the capacity to electronically receive information, the technical complexity and costs associated with interfaces, transmission or the submission process, and then the onboarding process for electronic reporting as being too cumbersome. Those were some of the top barriers. Fewer hospitals reported that they lacked the capacity to electronically send information, and issues related to standards or the lack of data not being stored in a structured format. And the rates that are reported here are based on a hospital indicating that they experienced that particular barrier for at least one of the reporting types that we have previously discussed in the other slides. Next slide, please. So overall, about 3/4 of hospitals, 73%, reported they experienced at least one challenge to public health reporting, electronic public health reporting. But this, again, also really varied at the state level, ranging from 23% to 100%. So that's something that I think worth noting, and thinking about when we discuss the data from the different jurisdictions, is that, different jurisdictions may vary. Hospitals report experiencing different levels of challenges, depending on what state they're located in. Next slide. So just to highlight top findings, most hospitals were submitting data electronically using fully or primarily automated processes for those that were required public health reporting, but that this was less likely to occur amongst hospitals with fewer resources for optional reporting types, and it varied across states. A majority, even though many hospitals are engaged in electronic reporting, particularly for the required reporting types, most of these hospitals also report that they're experiencing at least one challenge to public health reporting, and the top challenges relate to their perceptions that public health agencies lack the capacity to receive the information, and that the technical complexity and costs associated with submitting data, transmitting data are high, and difficulty with the onboarding process. I think the implications for this is that, overall, efforts to incentivize electronic reporting, through efforts by CMS to include them in, include these different types of reporting as part of the CMS promoting interoperability program, have been successful in improving rates of electronic reporting. However, that there is additional progress that needs to be made, particularly for those optional reporting types for hospitals that lack resources that may experience more technical issues. And it really highlights the need to improve public health data systems and remove barriers to entry in the process of electronically submitting data for public health reporting. And we'll continue to monitor this as we have been through future surveys of hospitals. So on to the physician findings. Next slide. Next slide. So, overall, about half of family medicine physicians report that they're able to access data from the IIS as well as report data to the IIS. So one would want to ask those two questions separately. When we look at the combined capabilities of being able to do both, that drops a little bit to about 4 in 10 family medicine physicians reporting that they're able to do both those capabilities. Next slide, please. Most physicians reported that they viewed immunization data from outside their organization using an EHR or outside portal, about 4 in 10 each for those two methods. Next slide. And the overall satisfaction, about 3/4 of family medicine physicians reported they were at least somewhat satisfied with their ability to electronic access external immunization data in their EHR or portal. But, only about 1/4 of family medicine physicians reported that they were very satisfied. So next slide, please. So with regards to family medicine physicians and immunization related data exchange, we can see that physicians are behind hospitals with regards to their engagement in electronic immunization exchange, data exchange, while 9 in 10 hospitals report that they're electronically sending data to IISs, in 2022, only about 4 in 10 report, engaging in that activity. And the methods that, they're using, there are still about 1 in 5 that are using methods such as paper or fax rather than using an EHR or portal. And, overall, there's a relatively high level of satisfaction among family medicine physicians, but as I noted earlier, only 1/4 were very satisfied. So with regards to physicians, there's just more work to be done. And even though the immunization registry reporting is required of eligible clinicians participating in the CMS promoting interoperability performance category of MIPS, it doesn't seem to have had as much of an impact as the hospital side because fewer physicians participate in the CMS program as compared to hospitals. So I think the depth of impact is a little bit lower just because fewer physicians participate in the CMS program. Additionally, the other lever is, just technical capabilities. And, the findings indicate, that CDC's DMI efforts underway, as well as efforts to improve the interoperability of EHRs and IIS systems could really help improve physicians' ability to report, access, and view immunization information needed to support patient care and population health. And with that, I will hand it over to Elizabeth. Next slide, please.
Thanks so much, Vishali. Hi, my name is Elizabeth Rubush. I'm a senior director with ASTO's Public Health Data Modernization and Informatics team, and I'm pleased to share a little bit of a complementary perspective from state and territorial health agencies on some of these data sharing aspects. On the next slide, we have a little bit of information about ASTO. For those of you who might not be familiar with us, we're the Association of State and Territorial Health Officials, and we support the Chief Health Commissioners in the states, territories, freely associated states, and District of Columbia. And as part of this mission, we also work to support the efforts of the health commissioners' leadership teams. So in the data modernization space specifically, ASTO convenes a peer group of informatics and data modernization directors who, of course, are key leaders in advancing data exchange efforts in their jurisdictions and also supporting this work nationally. On the next slide, I have just kind of like a high-level snapshot of some of the factors influencing public health data sharing as we're hearing them from our engagements with health agencies. There, as you can see on this slide, are an array of considerations and dynamics that can influence public health data sharing efforts, from state or national priorities around the collection, use, and exchange of data to governance and legal considerations, the nature of existing or new data sharing partnerships, technical capabilities, workforce, and more. So in my remarks today, I'll draw specifically from ASTO's profile of state and territorial health, in addition to some highlights related to data sharing from an environmental and legal scan that ASTO released earlier this year. So on the next slide, we have a brief overview of the ASTO Profile survey. The survey was launched in 2007 and is fielded every 2 to 3 years. It aims to provide a comprehensive snapshot and information on state and territorial public health agency structure, activities, and resources. It allows us to showcase the importance and scope of work conducted by the public health workforce and to monitor resource challenges over time. In the previous iteration of the profile, which was fielded in 2019, the survey was streamlined a bit and the informatics section was removed from that survey instrument. But recognizing the importance and the changes taking place in the data modernization space, the informatics section was reintroduced into the 2022 version of the survey. So we're pleased to report some of the preliminary findings from that informatics section. The full profile itself will be released in the coming months. When relevant, we'll compare findings from our 2016 survey to this most recent survey. And again, 2016 is the most recent survey where informatics, or the previous survey that we have where informatics questions were included, so we can show some changes over time. The ASTO profile itself is funded with support from the CDC and the Robert Wood Johnson Foundation. So we're so grateful for their support on this important data collection. And on the next slide, we'll turn to look first at electronic data collection in health agencies. So as part of the profile survey, we look at program areas and functions where health agencies collect, receive, and exchange data electronically. From 2012 to 2016, the number of states collecting data electronically increased across all the areas we surveyed. In our 2022 survey, we altered our question slightly to ask whether or not data were collected primarily through electronic means. So previously we had asked if data were collected electronically, yes or no, but recognizing how the field has evolved, we were now interested in understanding whether most of these data types were coming through electronically. So on this slide, responses from 2016 are featured in gray and 2022 are featured in blue. And we can see that in 2022, a majority of health agencies report primarily collecting data electronically for immunizations, laboratory results, reportable diseases, vital records, and newborn screening. And where we see some dips in the bars from 2016 to 2022, I think that might reflect the fact that we changed the question slightly, again, to focus on, whether most of the data were being collected electronically versus in previous iterations where we were just asking if they were collecting it electronically at all. So moving on to the next slide, we see some information about areas of improvement that are targeted in state and territorial data modernization plans. And again, this survey was conducted in 2022. There's been a lot of movement in this space just in the past year. So this is a snapshot of a period of time last year. 57 out of 58 responding jurisdictions indicated that they had either established or were developing a data modernization plan for their health agency. And of those 57, the most common areas of improvement within their data modernization plans were electronic case reporting, notifiable and reportable diseases, and vital records. And I highlight this because where states are prioritizing their modernization efforts more broadly might also point to specific opportunities for improving data exchange. On the next slide, we have some information around what roles are responsible for data exchange decisions within health agencies. So here we have two core measures looking at one, who is responsible for making decisions about policy and standards for data exchange, and two, who is responsible for decisions regarding public health information management systems. So that might include the maintenance and support, procurement authorization, and security policies related specifically to those information systems. For both of these measures in 2016, the role that was most often cited as holding overall decision-making authority was the Chief Information Officer, or an equivalent role. We're now starting to see what looks like increased diversification of who holds that decision-making authority. So for the first measure on the left and highlighted in orange, we're seeing now in 2022 that 43% of health agencies are reporting that other roles have primary decision-making authority. The Chief Health Information Officer is still in the mix, but it's for less, a smaller proportion, 23% of responding agencies. For the second measure on the right, highlighted in blue, we see that over a third of state and territorial health agencies report that the Chief Information Officer or equivalent has overall decision-making authority for their information systems. However, we also now see that a quarter of health agencies are reporting that other roles have overall decision-making authority as well. And the types of roles that were mentioned from our respondents who selected the other roles option are included in the notes at the bottom of the screen. And we see positions or roles like state health officer or health commissioner, chief information security officer, bureau or section managers, executive steering committees or management teams, and shared responsibility across multiple roles. So the range of roles across which decision-making lands, I think, is indicative of the complex landscape that data modernization leads and informaticians at health agencies are navigating. And as we conduct further analyses into these data sets, we'll also take a look at how this decision-making might vary by the state or territory's governance structure. So whether it's centralized or a decentralized governance structure. But in general, I would say the headline here is that decision-making is shifting from a more singular or centralized role that we recognized in 2016 as the Chief Information Officer. And we're now seeing that decision-making diversifying to include additional roles, or in some cases, some level of shared decision-making. The Chief Information Officer is still an important role that's in play, and you can see that in what's highlighted on the slide, but we are seeing some diversification in who's involved. So next, looking at the location of informatics offices, we're aware that some jurisdictions are starting to rethink the org structure of their informatics offices as they explore how best to advance data modernization efforts across their agency. In 2022, nearly half of the jurisdictions that responded, or 44%, reported that they have informatics offices that are centralized within the public health agency as a separate team, program, or division. Interestingly, 19% or 11 jurisdictions reported that there is not an informatics office in their public health agency or in another state government agency. And we'll be interested in digging in a little more here to understand how data modernization efforts are being organized in these jurisdictions. As far as how this all relates to data sharing decisions, this variety of org structures, I think, might impact, again, the complexity and layers of decision-making that might be involved in expanding or supporting existing data sharing partnerships. Next, I'll turn to some workforce aspects of the profile. And again, I think this gets at really importantly, what are the capacities and capabilities of the workforce in place in health agencies to support some of these data sharing efforts. So from this workforce angle, we see that about half of jurisdictions have an informatics career series or were developing one at the time. So again, in 2022. The other half had no plans to develop an informatics career series or didn't respond to the question. The number of jurisdictions with plans to implement a career series for informatics has nearly doubled since 2016. And interestingly, we're also seeing that agencies without an informatics career series are more likely to find informatics workforce recruitment and retention very challenging. So we have more information on the recruitment and retention angle of this work on the next slide. So in the all responding health agencies reported that attracting and retaining informatics staff is somewhat or very challenging. The top challenges that they cited were salaries not being competitive with the private sector, the lack of an established informatics career series or pipeline, so relating to what we mentioned on the last slide, and the lack of existing informatics position descriptions with specified skills, roles, and responsibilities. We know that some of our partners in this space, PHII and others, have developed some resources on informatics workforce classification and job descriptions. Also want to highlight CDC's Public Health Infrastructure Grant, which includes really important data modernization components. So we're hoping that we can leverage some of these existing resources and some of the newer investments to make some good headway in this space. So those are the preliminary highlights from the informatics section of the ASTO Profile survey. And as I mentioned, more complete findings will be available in the coming months. Very briefly, I'd like to shift to highlight some findings related to public health data sharing from 2 scans that were conducted as part of ASTO's COVID-19 Immunization Data Exchange, Advancement, and Sharing Program, otherwise known as our IDEAS program, which is funded with support from ONC. And the first report that I'll mention is on the left side of the screen. It's an environmental scan, which we conducted in 2021 and updated last fall, where we aimed to characterize the dynamics and factors influencing IIS, or Immunization Information System, and HIE, or Health Information Exchange, vaccination data sharing, both the status of those data sharing partnerships and any opportunities to expand them. And we conducted this environmental scan, with the broader aim of guiding implementation of our IDEAS program and a learning community associated through that work, where we're supporting health agencies and HIE teams and expanding some of their data sharing partnerships. The second report summarizes findings from a legal scan ASTO conducted in 2021 to better understand state level statutes and regulations impacting data sharing for 4 key areas. That's vaccination data, case and laboratory reporting, vital statistics, and syndromic surveillance. And again, both of these reports were developed with support from ONC. On the next slide, just some brief highlights from the IDEAS environmental scan. We have some snapshots of public health data connectivity with different types of entities. So the map on this slide describes the % of provider sites that are connected to an IIS via an HIE. And we can see that there is a wide range of public health and HIE connectivity for immunization data sharing across the nation, with just over half of jurisdictions indicating some level of HIE-mediated connections. And I think there can be a variety of factors driving this patchwork of connectivity. In some states, providers might already have an established direct connection to the IIS, in which case, making or creating a new transport mechanism through an HIE might be less of a priority. And I think the main question for us is here in the jurisdictions where there is an opportunity and interest in expanding IIS and HIE data sharing, what are the levers that we can pull to support this work? Our IDEAS learning community, like I mentioned, where we're supporting 5 jurisdictions and exploring just this question, is making some headway in this area. We'll hear from one of our learning community participants in the next session, I believe, and we'll look forward to sharing more findings with you from this effort as we wrap up the learning community. On the next slide, we have some information about specific provider types that submit adult vaccination data to health agency IISs. So it's a bit of a complement potentially to some of the data that we saw in the previous presentation. So this information is provided to us and included in our environmental scan, but generated by ARA, the American Immunization Registry Association, who's a really key partner of ours. And as you can see on this slide, IISs are most consistently indicating receiving adult vaccination administration reports from federally qualified health centers or rural health centers, local public health, and family medicine providers. I should also note that these data reflect any kind of data submission, so that might include direct data entry to the IIS and electronic submission, with electronic reporting being more prevalent. Finally, as noted in our legal scan on the next slide, there are a variety of statutes and regulations that can impact public health data sharing. Again, from immunization data, vital records, case and lab reports, and syndromic surveillance. Not all jurisdictions are able to share data uniformly, which is really important to keep in mind, as this legal landscape might impact broader national data exchange efforts. So I just highlight that piece to really bring to the forefront that is an important consideration for state and territorial health agencies as they engage in these efforts. And you can find more information in the report that I mentioned earlier. So on the next slide, we have some of our key takeaways. Again, a majority of health agencies report primarily collecting data electronically for reportable diseases, immunizations, laboratory results, vital records, and newborn screening. So that's some good news. The most common areas of improvement targeted within health agency data modernization plans are electronic case reporting, notifiable and reportable diseases, and vital records. The roles responsible for health agency decisions regarding data exchange and their information management systems are changing over time, and in some cases shifting from a more centralized role, such as the Chief Information Officer, to other roles or multiple entities and roles involved in joint decision-making. Nearly half of jurisdictions are reporting that their informatics offices are centralized within the public health agency as a separate team, program, or division, though the number of jurisdictions with this specific structure has decreased over time. And about half of jurisdictions have an informatics career series or were developing one. Finally, national efforts to expand data exchange must consider the legal landscape of state and territorial laws and statutes that govern public health data. And again, not all jurisdictions are able to share these types of data uniformly. So with that, thank you so much for your time, and I'm pleased to pass the mic along to our colleagues at UCSF.
All right, terrific. Well, I'm excited to round out this panel. Hopefully you will have a few more gulps from the fire hose of data left in you for this first presentation. You've already gotten a lot of information today, and I'm just going to give a bit more and sort of shifting perspectives. This set of presentations a little bit like touching different parts of the elephant to try to get a sense of this whole picture of data exchange to support public health. So the perspective that I'm going to address is Health Information Organization, or HIEs. You've already heard a bit about them in some of the other presentations, but thinking about these entities who really serve as sources to bring together multiple organizations' sets of data, and then be able to streamline the connection to public health agencies and back. So in concept, I think it's clear why HIEs might be well positioned to close public health data gaps. But prior to the survey of HIOs that we just completed, we actually didn't have any systematic data on the extent to which these types of organizations were really building capabilities to support. So that's what I'm going to talk about today, is our latest results that address that. Next slide. So I think we've already talked about the broader backdrop for this work on our efforts to modernize public health data systems and resources, and HIEs representing one potential strategy that could help move these modernization efforts along, because HIEs do serve as these large repositories of public health relevant data that could address gaps. And in particular, not just sort of, reporting some of the standard public health data, but being able to supplement that data with more information on things like race and ethnicity or geography that could address particular efforts within public health to look at equity. We know that health information exchanges have rapidly expanded over the past decade. We've surveyed them every year or two, starting since about 2017. And what we've seen is sort of an initial rise in the number of HIEs over time. And then recently more of a decline as the mature organizations we've seen a lot of consolidation and other approaches that sort of are helping these organizations, I think, find their place in the ecosystem and become more robust. So when we went out to survey them this year, we thought there were maybe 100 or so of these organizations that were operational, exchanging data across the country. But again, we didn't have any current data on their capabilities specifically to support public health reporting and how the COVID-19 pandemic shifted how HIEs had built capabilities around public health reporting. Next slide. So as I said, we've done this survey over many years, but each year we adapt it to figure out what are the most timely questions to ask. We also try to make sure that we know all the HIOs in the country so we can get a census rather than just a sample of HIOs. And so this year we were very lucky to partner with Civitas, who helped us get that complete, make sure our list was complete, and also helped us with increasing our engagement from HIOs in the survey. But we also went to some other sources, again, to try to get the most complete list. We started with about 135 organizations and found that 45 of them didn't meet our criteria, basically of being an operational HIO that was sort of a standalone entity, right? So if there were two organizations that merged, we wanted to make sure that there was just one response in our data for those two organizations. So in the end of the 90 that we determined met our criteria of an operational HIO, 76 responded to our survey, so an 84% response rate. So again, we didn't get everyone, unfortunately, but we hope that this presents a good picture of national capabilities. As I said, we had a new module in this survey that we fielded over the summer on both sort of general and COVID-specific public health capabilities. And you're the first group to see these results. It's always fun to have this opportunity to present results that are fresh off the press. And so you'll just see some of the high-level descriptive results and a lot more to come as we sort of dig into all the results and get them out in different formats for you to read more about. Next slide. Okay, so I'm going to start with just some of the key findings overall in terms of public health reporting capabilities and some of the barriers cited by HIOs in terms of their ability to support public health reporting. Next slide. So of the 76 HIOs that responded to the survey, 65 of them, or 86%, indicated that they either provided data to one or more public health agencies. And when we looked at where those 65 HIOs operated, it was in 45 states plus DC, so pretty broad geographic coverage. On average, each HIO connected to 3 different PHAs. And so if you take all those combinations and blow them out, it means that across the country today, there are almost 200 total connections between an HIO and a public health agency. You can see that about 30 or so of the HIOs only connected to a state level agency. A much smaller number only connected to a county or sort of smaller geographic unit. And again, just under 30 connected to both a state level entity and a local PHA. Next slide. So again, if you take that totality of 192 connections, just under half of them were bidirectional, right? Which meant that the HIO sent data to public health and public health sent data back to the HIO. And I'll just say that this is something we heard a lot about in our STAR HIE evaluation that we'll talk about in the next session, just of the value and importance of that bidirectional exchange, because both sides of that transaction have data that the other doesn't have. And so it was encouraging to see that almost half had that bidirectional exchange. You can see in just under 30 of the connections, it was only the HIO receiving data, which makes sense. It's sort of a little bit less obvious of a use case. And in about 70 of the connections, it was one way with the HIO reporting in to the public health entity. Next slide. So I think these results mirror what you heard in the other two presentations. When we asked HIOs what type of public health reporting is in production, immunization reporting was the top. You can see just over 60% of the HIOs that were engaging in some form of public health reporting were doing immunization registry reporting. This was followed by electronic reportable labs, syndromic surveillance, and then you can read down the list. You can see vital record system reporting was the lowest on the list. Next slide. So we asked about barriers to public health reporting. And again, this is from the HIO's perspective. I think it's always a little tricky to ask about barriers when you're not asking about both sides, but this is from the HIO's perspective. What did they perceive as barriers to be able to expand and grow public health reporting? And the top major barrier you can see was limited funding. Again, I think not a surprise that that's going to be a limitation if they're limited funds, right? These connections are still expensive to establish and take work, both in terms of technical and human capital. So that makes sense as a top barrier. Other priorities that the PHA has, especially coming out of the pandemic, right? It makes sense that maybe their top priority is not necessarily establishing a connection to an HIE. PHA is lacking staffing, and then the fourth barrier was around lacking some of the technical capability to process the data feeds. Next slide. Okay, so those were the overall results in terms of HIE's current capabilities to support public health. We did ask about some of the COVID-19 specific capabilities. So let me share those data with you now. Next slide. So 61% of the HIOs, again, that had some type of public health connection indicated that they provided data to fill gaps in COVID-19 related data. So that could mean any types of different additional information like race, ethnicity tied to COVID-19 testing or test results. An additional 31% said that they could do so, that they were positioned to be able to fill gaps, right? So that's like well over 90% of HIOs who have this ability to take the breadth of data that they have available and connect it to COVID-19 data to be able to enrich the data before it goes to public health. Down below, what we asked is basically, what data do you, the HIO, have available that could be used to help monitor health equity? So beyond just sending an immunization or a lab result, could you enrich that data with some additional information that might be particularly useful to health equity assessments? And so you could see that 88% of HIOs could enrich data either with race ethnicity data or home address. 74% could add preferred language and then gender identity. And you can see just over half could add data to give a better picture of health-related social needs. So again, a very rich set of data that HIOs do have available that could provide a better sense to public health of not just the core public health data, but these additional equity-related data fields. Next slide. We also were curious whether since the pandemic, HIOs had been able to expand provider participation. I saw in the chat this comment about some of the most valuable data could come from EHRs. And so we were curious, like after the pandemic, did HIEs see an increase in participation from, for example, hospitals and health systems and ambulatory clinics and practices that are then connecting their EHRs to HIEs? So you can see those were the top most types of stakeholders for which HIOs were able to expand participation. Unfortunately, as you look down the list, behavioral health, correctional facilities were not quite as high, and long-term care and labs were a little bit more in the middle. So if you think about now the breadth of data that HIEs have coming out of the pandemic, Again, I think they've always been strong on hospital health systems and ambulatory clinics, but we are seeing some signs of growth in labs and long-term care, again, where we know there was a major focus in the pandemic of recognizing that they held high-value public health data. Okay, next slide. Okay, so as I said, a little bit more data to round out this presentation. When you look, stepping back from the data, I think that together the results suggest that HIOs are well positioned to support public health infrastructure modernization efforts. Again, they're focused on some of the key public health reporting needs and have this additional breadth of data that could be used by PHAs to have a better ability to understand some of the health equity implications of the data. And HIOs are unique, even though they, don't necessarily have all the data in a given region. We did see that they're expanding participation and they're able to link and deduplicate data. Again, I saw this comment in the chat. So they really are providing sort of a valuable sort of middleware solution, right, between the provider systems or the lab systems and public health. So as we look and think about how can HIOs continue to grow and ensure that they are providing even greater value to public health, CDC's data modernization efforts to improve public health data systems, as well as ONC's Public Health Informatics and Technology Workforce Training Program, we think will be helpful, in particular in addressing some of the key barriers we saw in these data to HIO-PHA connectivity around some of the funding and skill sets available. So we hope that this means that we are on target to enable PHAs to better take advantage of capabilities that we now have data to show exist. So that's it for me. I'll turn it back over to Vaishali.
Great. Can we move to the next slide, please? Or the slide after that? Actually, the slide after that. All right, so we're moving on to the Q&A and discussion. And as part of this, I tried to pull together the next slide with this one. Yeah, I tried to pull together some basically findings across the different perspectives, and including public health, from Elizabeth's presentation, from the presentation I did related to hospitals and physicians, and then Julia's presentation on HIOs, so that we could, as Julia described it so wonderfully, touching the elephant, different parts of the elephant, because each brings a unique perspective on the process, and so it would be good to just basically compare notes across the board here, and we can also address any kind of outstanding questions as it relates that might be in the Q&A and chat. It looks like most of the questions, I believe, were answered. One question, quick kind of technical question, before we kind of move on to this broader discussion. Elizabeth, one question was like whether direct messaging was included as part of the HIE definition in the presentation that you did. And this is a question by Chris. I'm going to probably mispronounce your last name, Chris. That's CYR is the last name. So I don't know if you have that handy or if that may be something that you might need to circle back on.
We've used the definition for HIEs that was included in 21st Century Cures, I believe, so kind of relied on some of that language. The HIEs that we're engaging with in our learning community are often the state designated entity for health information exchange. And in one case, we're working with a health center controlled network that specifically facilitates exchange across a number of federally qualified health centers. So most of them cover the entire state, and like I said, in that one instance, we have a data partner that focuses on supporting exchange amongst federally qualified health centers, which was a key population that the jurisdiction was interested in having more nuanced information on.
Okay, great. And I think, Julia, there's one other technical question that related to like whether we had included like EMSs, like connections between HIEs and EMSs in the survey or not. And I couldn't recall off the top of my head.
I know that we have asked about it on prior surveys and whether we still have that on our latest survey. With 5 minutes, I could check. So let me try to do that and respond. It wasn't specifically within the public health section, but we did on the survey ask a broader question of what types of stakeholders are connected to your HIE. And I just can't remember if they're on our list or not. My guess is that they are, but I can confirm that.
Okay. And some other questions are coming in the chat. Steve Eichner is asking how many HIEs are routing but not reading data to public health. I don't know if we get into like that level of detail in the survey, or maybe Elizabeth, you might have some insights into this. I'm not sure. Some individuals may choose not to participate in the HIE. How is data retention by HIEs managed in various jurisdictions? I don't know if the survey really gets at that, but.
Yeah, I would say our survey does not. I think, and again, STAR HIE evaluation we did here, if I'm understanding the question correctly, like, about PHA's ability to really work with all the data they're receiving from the HIE, and we heard varied perspectives, like some that were and some that found it challenging, to work with the data. So if that's your question, I think there is variability in those capabilities, but that's something that we heard that PHAs were very motivated to address because they want to be able to take advantage of all the data that they're getting.
Right, and Lisa Barry is helping answer the question in the chat. So thanks, Lisa. Appreciate you chiming in there. And then are there any state public health agencies, I think, Elizabeth, managing or funding HIEs?
I think we're seeing varied governance models for that as well, and a shifting landscape as far as I can tell. So I think we are aware of, some situations where the HIE is kind of looking at or moving towards like a health data utility model, in which case they often do, receive like support from the state itself, and are viewed as a critical partner amongst multiple state agencies. But I would say there's really not like a one size fits all structure that we've seen. And so we're seeing some models where they're kind of a public-private partnership supported by the state or functioning as a private entity.
Great. And it looks like some folks are chiming in the chat with some examples here. And I think, Elizabeth, one other just call, and not necessarily, is a call for having some kind of exchange of development for informatics careers, like what training is provided, job descriptions, salaries, et cetera. I think that might be helpful for different public health entities.
Yeah, that's an area that's of importance for us, and we're really focusing on specifically through the public health infrastructure grant that was awarded through CDC. ASTO is one of the national technical assistance partners. I think as part of that work, looking at the data modernization workforce, revitalizing some of the materials that have been created in the past around some of those career or position roles and responsibilities, and also sharing amongst some of the jurisdictions, some of the career pathways that are being developed, job descriptions, et cetera. That's certainly something that ASTO aims to support through this work.
Okay, great. All right. So yeah, let's maybe kind of touch on some of the kind of themes that have come out related to the current status. On the provider side, there is variation between hospital and physicians' engagement in public health reporting. Hospitals seem to have a higher level of technical capabilities, although it does vary based on the resources the hospital has and the type of public health reporting, whether it's required or not. On the public health side, it seemed that, a majority of public health agencies reporting that they were primarily collecting data electronically for some of those sort of key kind of reporting types. And based on some past work that you had done, ASTO had done, about half of jurisdictions reported specific to immunizations that they were mediated by health information exchanges. And that HEOs, most of them were, were engaged with public health agencies across about 45 states. And that half of their connections were bidirectional. And again, it seems like certain types of reporting, particularly like immunization and lab reporting, kind of are amongst the most common forms of electronic exchange. It seemed like immunization reporting was like a bit of a bright spot, just based on, across the three findings. And it may be that, there's a lot of work being done in this space too. So I don't know, Elizabeth or Julia, if you guys had any thoughts about that based on not only just these survey results, but I know, other work that you've done, Julia, for example, in the STAR HIE program that you'll be talking more about in the next session. But
yeah, I mean, I think, there are definitely, examples of sort of where it felt like the alignment was there between like the capabilities that the HIO had. Oftentimes, right, it was an HIO that had a lot of, kind of providers in a given geographic area well connected, so they had good coverage, and then that directly allowed the public health agency to feel like with one connection to the HIE, they were getting like a breadth of data, and it wasn't just like, oh yes, this is just one more pipe in, that gives us just a little bit of data. So I feel like, if the HIE had good coverage that overlapped with the jurisdiction of the PHA, and then, had, frankly, just the staff and resources to be able to make sense of and understand the data. I think that to me felt like when we heard, the most success. Increasingly too, and again, I will talk about this a little bit in the next session, partly what happened during the pandemic was that I think public health agencies just got a better understanding of what HIEs can do and their capabilities. And that allowed them then to envision many more uses of the infrastructure and data. And so for me, that was honestly one of the biggest bright spots, was just hearing like, that there was just more understanding of what could be possible through the partnership, and more forums in which the two types of entities were regularly interacting to discuss a growing set of opportunities. So I think that the pandemic really did sort of move us forward in that respect in terms of the relationship building and starting to use the capabilities, but I think we'll see a lot more growth there.
Yeah, just to add on to that, I mean, I do think that at its core, a lot of this is relationship building work, where we see a lot of opportunity to do that when we go through public health emergencies, but the hope being that we can maintain some of these new partnerships that were forged during an emergency, so that we can build on that during times of more calm and be prepared for the next challenge that hits us. I think some of the factors that I've seen that seem to support some of these collaborations are when the nature of the data exchange is in alignment with some broader health agency or state priorities. So being able to, I think, understand how this work connects to the bigger picture that a health official or a state is looking at is helpful. When there's a solid use case for data sharing, I think starting small with a solid use case can open the door to explore a lot more opportunities, but really honing in on something that's meaningful to both sides of the partnership is helpful. and a clear value proposition. I think in many cases, when folks haven't worked with one another, there's not a clear understanding of the assets and services and strengths that HIEs can bring to public health. So having conversations about what some of those capabilities are, developing a strong value proposition, and recognizing that that value proposition might look different for public health than it looks for the HIE, I think is pretty important. And finally, I think I often see this work move forward when there's a strong champion supporting this work on both sides of the partnership. So my suggestion would also be, if you're starting in one place and not getting a lot of traction, there might be other program areas or data types where there might be receptiveness to explore some of these partnerships. And when there is that demonstration of what's possible, you might see willingness and interest from other areas of the health agency.
Great. So I think we're at time, unfortunately. I wanted to go a little bit deeper into this topic, but I appreciate and thank Elizabeth and Julia for sharing these findings and really shedding light on how the pandemic, with all its obviously stresses that it's put on the public health system, has also brought to light these issues that are now being addressed through various means. So really appreciate it. And I think we will move on to the next session and slides. The next session is going to take a look at a deeper dive, peeling the onion on what we just discussed with, Julia and Elizabeth, and doing a deeper dive into public health data exchange and focusing specifically on the role of networks. We are going to be starting this session with Michelle Miggs, who's the director of the Informatics program at the Association of Public Health Laboratories. Michelle will be discussing the evolution of the Informatics messaging services platform known as AIMS, that has helped securely transport millions of messages on a monthly basis across public health jurisdictions. Following Michelle's presentation, we have Julia Adler-Milstein back again. For those who are just joining us and were not part of the first session, she is professor at UCSF, and she leads the Division of Clinical and Health Informatics, a newly formed division of Clinical Informatics and Digital Transformation. And her work sits at the intersection of clinical informatics and health policy. And she focuses in particular on the evolution of health information exchange and interoperability. And in this particular session, she's going to be doing a deeper dive on the role of HIEs, with a focus of evaluating findings from an evaluation that she led of grantees, some grantees that participated in the strengthening the technical advancement and readiness of public health via Health Information Exchange Program, also known as the STAR HIE program, which provided $5 million overall to strengthen and expand the ability of HIEs to support public health agencies in their response to public health emergencies and pandemics. And then our final presentation will be jointly done by Brian Fowler and Dan Paoletti. Brian Fowler currently serves as the Chief of Public Health Informatics at the Ohio Department of Health. He engages the agency's data governance activities, acts as a liaison with Ohio's Health Information Exchange, and oversees Ohio Department of Health's interoperability activities, including the automation of data feeds. Dan Paoletti is the Chief Executive Officer of the Ohio Information Partnership. Previously, he served as Vice President with the Ohio Hospital Association and Chief Operating Officer of OHA Solutions. Dan and Brian together will be describing Ohio's participation in the Immunization Data Exchange Advancement and Sharing Program, also known as the IDEAS program. IDEAS is an ONC-funded project with ASTO that helps facilitate and support COVID-19 immunization coordination between public health officials and public health informatic officers with HIEs at the state and local level. So with that, I will turn it over to Michelle to discuss the AIMS platform.
Thank you, Vishali. Good afternoon, everybody. Thank you so much for this opportunity to talk to you all today. I am sure that you've heard of AIMS and you are, you know, a little bit or a lot. However, I'm hoping to kind of level set not only on the AIMS platform as a quote unquote public health data exchange intermediary, which is kind of a new term that has been coming up as part of our efforts with the Data Modernization Initiative, but also to really show why something like AIMS, as well as other intermediaries like ReportStream, are so critical to moving our public health agencies and labs forward as we try and meet some of the goals of the public health data strategy. Next slide. So a little bit about APHL, just in case you don't know, we are a 501(c) nonprofit, and at our core, we are a membership organization. However, over a long-standing, I mean, probably close to 35, 40 years, we have had a long-standing cooperative agreement with our CDC program partners. And so, you know, the organization in and of itself is about 90% funded by a cooperative agreement. Next slide. And part of that cooperative agreement, we are funded to support an informatics program. This informatics program is really the core of what we're going to be talking about here, right? So we are a smallish staff, which we're starting to ramp up and really kind of stabilize our staffing model as we come out of as we're coming out of the pandemic. But our goals remain the same, right? Since I started in 2005 at APHL, our key capabilities and goals have really been around strengthening the core of public health. And then as we shifted our focus from just pure nonprofit work, where we were doing advocacy and, you know, policy work, and shifting towards more of a technical focus, we really wanted to make sure that we can continue to ensure equitable open access to both AIMS, as well as services that have proven to have helped to help advance public health data exchange over the years. Next slide. So let's level set. I'm not going to go over this again because I think that the presenters, Elizabeth and Julia, have already discussed this, right? So the public health reality is just this, though. You know, there's many challenges when it comes to ensuring that our public health labs and agencies can move forward on data exchange technology and adoption. I think the biggest one that we've been seeing both during the pandemic and after is really that kind of accumulated technical debt, really understanding how important it is to continually invest in and support technology as we need it, as opposed to trying to go back and fill that gap. The labs and agencies we work with are really struggling right now to really change and pay back that technical debt so that they can move forward into the future. Obviously, there's lots of competing data needs and priorities. And then we have spoken already about this limited access to technical expertise. The specific notes on the screen here show are actually from the public health laboratory setting, where I think we had a response rate of about 46%. And they said 86% of them said we do not have the resources to support not only the current work that we're doing, but also future work. Next slide. So this is really where intermediaries like AIMS or ReportStream or others as well can really provide really amazing efficiencies. This is a very busy slide, and you guys can look at it after the fact. But what I was trying to show here is that, yes, something like AIMS has the technical capability and the shared infrastructure to support these agencies and labs around transformation, transportation of data, standardization of data. But then you have to have the processes around it that will also support these data moving forward. So including shared tools and infrastructure, as well as technical staff and expertise that can be deployed when needed, and really get folks over the hump. So this really does serve as an important reminder that although technology is important, you need other pieces around it that will help to move the needle forward. And we've seen this from the beginning. Next slide. We've also seen that the use of an intermediary can really help kind of balance out some of the health equity, meaning that a still can actually contribute as much or as little as they need to or have access to, and support their own needs. However, if you have an intermediary along with technical assistance or a workforce acceleration program, that can really help support lower resourced organizations and agencies. A great example is a project that we've been working on recently with LA County, who basically, because of the Mpox outbreak, really realized that they were in deep trouble. They could not get data out of their systems. And so we helped them through technical assistance to really, provide them the expertise they needed, because at that point, the lab director was actually helping to support data exchange activities within LA. It was crazy. You would never expect that, but that's where we are in some instances. We were able to connect them to AIMS, connect them to the public health agency, and provide them the technical assistance they needed to get these data in the correct format and moving on its way. Next slide, please. So let's talk about AIMS. AIMS has been around for quite a while. It's been around since 2008, but really and truly, as an overarching kind of view of what AIMS is, it's really a cloud-based data exchange platform, right? It has served our CDC partners and programs. It has served public health labs, agencies, providers across the numerous amounts of use cases. It is hosted on the AWS platform, and it right now has, I think, the capacity and the scalability necessary to really move forward into the next generation of work that we need to get done. Next slide, please. So on the left-hand side there, that is a really unreadable kind of infrastructure diagram, architecture diagram of AIMS. When you get these slides, I'm sure you can expand that and take a look at it, but it kind of shows all the different environments and all the different servers and pieces of the infrastructure that needs to happen. However, of course, it didn't start out there, right? So if you were to look at the platform history over, since 2008, to Steve's point, we started off as basically a route not read hub, right? We were the post office. We were getting these data from public health labs, moving it to CDC programs to help support flu surveillance. And it wasn't until 2010 that we really were able to see progress, where we were putting people on the ground in the organizations to help move these data based on project needs. Very quickly, though, we needed to modernize ourselves, right? We really needed to say, what do we need to scale? And so we worked with our partners at AWS and within other organizations, and we did move the cloud, made the move to the cloud in 2014. And that was a big deal for us, and it scared a lot of folks within public health, because there were a lot of concerns at the state level about whether or not they could and should or will adopt cloud-based systems, security being a major issue. So fast forward into end of 2019 and then into the lovely years of 2020 and 2021. This is where we saw some of the technical debt that not only our labs, but also the Ames team had kind of dug a hole for themselves. COVID hit strong and the focus was really on that data exchange capability. Because we did have some really important data feeds already in place, like Quest ELR and others, we were able to leverage some of that infrastructure and leverage some of the tools to basically scale up capabilities. But it was not easy. I think the biggest example of where we had to make the hugest jump was around electronic case reporting and the ECR Now Fire app, which allowed COVID data to start moving to jurisdictions. This really kicked us into high gear, and we just had to buckle in and see where it all went. During the pandemic, we were continuously working on our accreditations, our security protocols, and all those things that needed to be in place. So that kind of foundational work that needed to happen outside of the technical work. And so here we are in 2022, and then moving into 2023. We have been working on almost resetting post-pandemic, right? We need to understand what's valid, what's not valid, how Ames fits into the greater public health data strategy and data modernization initiative, while we are also continuing on the existing projects, which I will give you a quick insight into. Next slide, please. So as you can see by this wonderful / horrible diagram, I am not a graphic designer. However, what I was trying to do here quickly, and I did not have time to make it pretty, was to kind of show all of the different use cases that are on Ames, quote unquote, projects, right? So these are funded through our cooperative agreement, and we work with our technical monitors to not only help support the end users like the public health agencies, but also programs. Each one of these projects has vocabulary component, it has the standards, it has tools, and then it has all of the functions that it takes advantage of on Ames. So this includes secure transport, transformation of messages, online validators, which we have a multitude of, routing and batching of these data, some in terms of storage. So we have to store data to ensure we can requeue it within a certain amount of time. So we've got very strict rules around data retention. And then we also have tools that needed to be hosted on Ames to support various program activities, as well as to support data exchange between partners, where they just needed to collect data or submit data for a specific grant requirement or a program. And then obviously we're helping to visualize these data as well, not so much from a data visualization standpoint, that's not in our wheelhouse really. It can happen from a program perspective, but more from a message quality and connectivity standpoint. Are my messages moving? Do I have, it gives folks kind of a visual cue in terms of how much data they're sending and whether or not it's being received correctly. So it opens up a little bit of transparency to make sure that folks are comfortable with the data and how it's moving. This will be starting to expand over the years, and then also we will also be looking at moving a lot of those hosted systems to other areas of potentially within CDC. So we're working really closely with the CDC DEX team to migrate some of these data lakes so that so that we can support the CDC vision of having kind of that national trust and data repository within the CDC, which I think is great because in my mind, these data shouldn't live on Ames. What we are is a data exchange platform, making it easier and simpler for public health to focus on their work as opposed to the plumbing that has to connect all of us together. Next slide, please. So how does this translate into impact, right? So I've taken Alaska as an example, but this shows how many data feeds a lab or an agency are participating in on AIMS. There are several different work streams that are happening, and that translates into a heck of a lot of data within these data feeds. So we have 166 public health feeds, both going for various different activities, such as the antibiotic resistance lab network, laboratory response network, and then obviously our FLIP data feed, which is the beginning of it all. That's what we started with in 2008, which was actually reused and able to scale relatively quickly to also include COVID data. We also have 324 public health agency feeds across the country. Okay, next slide, please. So here's where the fun stuff comes in terms of volume of data. So as you can see, this is a full month of data just for August of 2023. And as you can see here, you can see that we've processed or received 10.4 million messages. Doesn't sound like a heck of a lot, right? It's impressive, but not huge. However, if you go to the next slide, you can actually see what this translates when those messages are actually massaged and routed appropriately. So because we are doing a lot of batching of data, the stats you saw on the last screen is really just when it hits our front door, right? It hits our front door, it comes in, and then we need to figure out what happens. And that's where Mirth really gets down and starts to do all the hard work. And so if you look at the sum received and the sum sent, we can then understand what that 10.4 million messages translates into, and that translates into 890 million messages. Not really, but you know what I mean. So this is data from the past 6 months. And as you can see, this actually constitutes the true sense of how scalable AIMS has become over the years, and has allowed us to really kind of scale up not only the amount of data that we can send and transmit, but also has identified areas where we need to improve. So one of the things that we will be doing relatively soon, which will help to support ECR and other efforts, will be to go to a more commercial Mirth version. And we are doing a full restructuring of our Mirth channels, especially for ECR, which makes up close to 70% of our data volume, which I think is very telling. So we are looking at making sure that we can take advantage of better technology as it becomes available, and we're able to scale when necessary. Next slide. Okay, so I'm just going to quickly, because I'm running out of time, I'm going to quickly go through 3 examples of how AIMS has supported projects. I'm going to talk about an established project like the project on the screen here, which is the Quest ELR project. I'm going to talk about ECR, and then I'm going to talk about, which is kind of an evolving but extremely important project, and then I'm going to talk about eTOR. So on the screen here, you just see kind of a data flow, how data moves through AIMS for Quest ELR. AIMS since 2015 has been working with our CDC colleagues within NCEZID to support the transmission of Quest data to jurisdictions, which has been amazing. I think it increased our national ELR by close to 8 points. Which was a huge boon for our organization, for our public health agencies. Next slide. And the way that we did this was really through strict project scoping. We obviously said we needed to use AIMS, and then we needed to provide the tools and services to support both the sender and receiver, so both Quest and the public health agencies. And because of that, we were able to make progress much quicker. And show the advantage of trying to move these data through an intermediary as opposed to having, running into the issues where the agencies are constantly figuring out how to engage with their partners and then running into challenges to do so. Next slide, please. So then let's talk about ECR. This is the darling of data exchange right now. I think it is an amazing project, and I'm sure most of you know this. However, I do think that the complexity of the ECR infrastructure really speaks to how complex some of the requirements have to be between public health agencies and their healthcare organizational partners. So, looking at what it would take to build some of this capability individually, it boggles the mind, both from a cost perspective as well as a time and an expertise perspective. And so, in coordination with our CDC colleagues and with basically an army of consultants and staff, we have been able to build what you see on the screen. And the ECR team has just been amazing in terms of figuring out how to do this onboarding in a really streamlined way through the EHR vendors, and also by connecting to our partners at eHealth Exchange. Next slide, please. And so as we're evolving and as we're making progress, we wanted to give you a quick sense of where we are with ECR. And I think Jen mentioned this before, we've got over 28,000 facilities. Facilities. And the one thing I wanted to point out on this screen is that we have already hit one of the critical public health data strategy goals of at least 25% of critical access hospitals. Next slide. I will skip over this. You guys can read this yourself. This is about fire, but I am way over time. Next slide, please. And then finally, future eTour. What we're trying to do here is to leverage what ELR and ECR has already done in terms of technology, processes, and relationships to facilitate eTour. So this is kind of the next generation of connecting public health laboratories with their healthcare organizations. Our first use case is around newborn screening, and we are looking at how to support that kind of 24/7 need for healthcare organizations to monitor and maintain and support the health of newborn babies. Next slide, please. And so just to close out, as we continue to make progress on all the critical path public health data strategy goals, we will continue to evolve the tools and services on AIMS. We will continue to work with our partners at ONC and CDC and make sure that AIMS is here for the future. So, thanks so much.
Great. And I think we'll now move on to Julia Adler-Milstein and the evaluation of the STAR HIE program.
Okay, thanks so much. I'm back and excited to talk about the STAR HIE program evaluation. Next slide. So for those of you who aren't familiar with the STAR HIE program, it was a in total $5 million cooperative agreement program that had a specific focus on strengthening and expanding the ability of HIEs to support public health agencies in response to public health emergencies in general, and obviously, given the fact that it happened over the past 3 years, a specific focus on COVID. The first award, which was $2.5 million, had 5 original STAR HIE awardees, and that was the focus of our evaluation. But 4 of those 5 awardees, as well as 17 others, did receive a supplemental award focused on connecting HIEs to immunization systems, which was not the focus of our evaluation. So again, you're going to hear about just the 5 original STAR HIE grantees. And that program had the specific objectives of building innovative HIE services that benefit public health agencies and improving HIE services available with a particular focus on supporting communities that were disproportionately impacted by COVID-19. And you can see the names of the 5 STAR HIE recipients, again, the original 5 group that were the focus of our evaluation. Next slide. So it's very hard, I'd say, to summarize all 5 of them in a short amount of time. I will say on the whole, 3 of the 5, GHIN, HSX, and Kanza, so in Georgia, Pennsylvania, and Kansas, largely had a focus on electronic lab reporting and electronic case reporting, trying to onboard more providers to those services, as well as focus on sort of different particular settings. So for example, GHIN had a focus on correctional facilities and rural hospitals. HSX had some focus on long-term care. So each of them, again, had a little bit of a different spin, but on the whole, I'd say that those 3 had a similar set of activities. Next slide. Again, this is the Kanza piece. And then THSA had a bit of a different focus. So theirs was on trying to automate situational awareness reporting of factors that we knew became really important during the pandemic, like PPE, ventilators, hospital capacity, and in particular using the SANER fire standards as the basis of that automated situational reporting. And again, given that that's sort of an early staged set of standards and type of reporting, they focused on recruiting a pilot hospital to do that initial development work with. Next slide. And then Contexture, which was sort of formerly known as Health Current of Arizona, originally actually had a similar focus to THSA in terms of thinking that they would focus on situational awareness data, reporting of federal and state mandated PPE, supplies, et cetera. But ran into some challenges with that actually also THSA ran into that I'll speak about in a minute in terms of the challenges, and decided to pivot under the award and rescope to focus on something that was considered really important for advancing public health in the state of Arizona around developing a master person index that could serve different types of stakeholders, including the Arizona Department of Health Services, as well as the Medicaid agency and their health cost containment system, so sort of public health, Medicaid, et cetera. So they focused on sort of planning for that MPI in a way that would serve specific public health needs. So that's, again, very brief overview of the awardee activities. A lot more obviously to say about their scopes, but I want to move on to the actual evaluation results. So next slide. So how did we evaluate these 5-star HIE awardees? What we wanted to assess was how the program impacted their relationship with the public health entities that they engaged with. There was a particular focus on understanding whether HIEs could serve to alleviate reporting burden, both on the provider side and on the PHA side. Again, they serve as this intermediary role. And so understanding of that was helpful in terms of reducing reporting burden reduction. Interested in thinking about the sustainability of activities that were funded under the award. Would they continue after the award ended? And opportunities for replicability and lessons learned, so that these 5 can help inform the broader set of HIEs across the country as they are thinking about their approach to engaging in public health reporting. And then obviously some of the specific successes and challenges as they were going through the program and trying to meet milestones. We did an interim evaluation sort of midway through the program. It ended up being about a 2.5-year program, and then just finished our summative set of evaluation activities now that all of the awardees are either sort of officially finished or very close to finished. So what I'm going to present to you is really a sort of the best of all the findings that we learned across both the interim and summative evaluations. Next slide. So we tried to glean insights in both a quantitative and a qualitative way. So we were interested quantitatively, could we actually measure progress in advancing HIE under the program? So we asked for the participants to develop a set of measures that made sense given what they were working on. And so in some cases, these were measures of things like an increased number of participants who were able to be onboarded for public health reporting because of the funds from the STAR program, or an increased breadth of data exchange or volume of data exchange, or things like improved data quality completeness. So I don't, again, have time to show you all the results today, but I'll show you some snapshots that hopefully give you a sense of what they were able to accomplish in terms of the measures of direct measures of progress. And then it was also really important to get the qualitative here, allow people to say in their own words what the impact and challenges of the program were. So we did an extensive set of key stakeholder interviews. Some of you who are on this call today, we interviewed, and we intentionally really tried to get a multi-stakeholder perspective. So not only the awardee, but some of the participants, some of the technical partners, obviously the public health agencies that they were working with, and tried to triangulate across those perspectives using an implementation science framework. So what I'll present to you today is the high-level themes that emerged across awardees. Okay, next slide. Okay, so again, we worked with each awardee to figure out what quantitative measures made sense to produce and report to us based on the activities that they undertook during the program. Based on, as I said, GHIN, HSX, and CONSA that really advanced electronic lab reporting and electronic case reporting. They had sort of a similar set of measures, and THSA and Contexture didn't really, again, given the nature of their work, have the right set of quantitative measures to report. So you'll see quantitative measures from the first 3 awardees. Next slide. Okay, so now I get to get into the fun stuff. Again, this is just going to be a really highlights tour of it. So this is data from HSX, where we asked them to be able to show us under the program who they were able to newly onboard to support public health reporting. And what was notable here is that HSX was able to onboard over 150 post-acute care organizations. Again, we know during the pandemic, this was a really key setting to be able to monitor, oftentimes without as robust HIE infrastructure to connect long-term care facilities to HIEs. And what they did was to partner with a particular long-term care vendor that had a hub and spoke model so that they could connect just to that hub and be able to get data feeds from all of these different post-acute care organizations. So again, you can see they were able to onboard lots of different types of organizations, but just had this particular growth in the post-acute care space. Next slide. Okay, so here's some data from CONSA on their electronic lab reporting volume. So again, what you can see is the different facilities they onboarded to show that they were able to increase the lab data. And they worked with a particular set of ambulatory EHR vendors. So they I'd say, focused their investment on getting the technical integration to work with a set of ambulatory EHR vendors that then brought those ambulatory clinics on board. And then we were able to see, again, the results of the reporting. What we did was to map it against the new COVID cases in Kansas, so we could actually see if the reporting tracked the spikes in cases. And you can see really nicely here that you can see that those case reports do, the lab reports do spike when we knew that there were increases in COVID outbreaks. Next slide. All right, here's some data from GHIN that stood up electronic case reporting with a major regional health system. Again, you can see that they were able to be successful in really increasing case reports that, again, tracked with the COVID case volumes in the state of Georgia. And again, in a pretty short amount of time, just from this one health system, had over 25,000 electronic case reports submitted to the Georgia Department of Health. Next slide. HSX stood up a COVID registry. So again, you just see this very consistent pattern of being able to report, the COVID-19 test results that tracked, by and large with the COVID cases. And here you could also just see the growth of patients who were added to the registry, so that there was a growing number of ultimately over 1.1 million unique patients who were represented in the COVID registry. Next slide. Okay, and last but not least, here's some data from CONSA that was able to show that they were able to improve the completeness of race and ethnicity data. Again, what they did was to set up a COVID registry that was able to bring together data from multiple participants, so that if a COVID-19 positive test result came in but didn't have race and ethnicity data completed, but they had that race ethnicity data in their master patient index from another source of data for that patient, they were able to match them up together. Again, this is, I think, the core value, one of the pieces of core value that HIEs provide. So they were able to improve race and ethnicity data completeness from, around 92%, which was good, but basically to almost 100%. And so it was nice to be able to see in the data this particular focus that they had on data completeness and how they were able to achieve it. Next slide. Okay, so that was a quick spin just to give you a sense of some of the quantitative measures and how we were able to see progress during the program in those different dimensions of bringing on different stakeholders, getting increased data feeds, COVID-19 registries, and data completeness. I want to now just use the rest of my time to go through the qualitative themes. Again, you can see the interviews that we did in the second round. I did 36 interviews across the different recipients, again, trying to capture these different perspectives for the recipient itself, PHA, technical vendors, and the participants who were participating. Next slide. All right, so there are sort of 5 key themes that we, after analyzing all the interview transcripts, came away with. So let me just walk through them. Again, a lot more to be said about each of these, but I want you to have at least the high level results. So we did see a lot of success for HIEs under the program. They were able to build out electronic lab reporting and electronic case reporting, in particular, using their capabilities to have more complete data. Again, that's because they had a lot of participants that were connected and were able to do the matching and deduplication to ensure that each individual lab report or case report had more complete data. In general, we heard just a lot of success that, different settings wanted to switch to electronic reporting. During and coming out of the pandemic, they saw the value of doing that and being able to reduce the effort in manual reporting. And so they didn't find a lot of resistance from the participants in making that case. And again, the HIEs, because they were doing this over and over again, could pretty quickly figure out how to convert new sites to electronic reporting. And as I said before, right, multiple awardees were able to get to this more complete data by combining existing data feeds and their MPIs to be able to supplement COVID-19 related data completeness. Next slide. So we also saw progress with some of the novel technical approaches and reporting use cases like situational awareness reporting, but there were more substantial challenges because those were just less mature use cases coming in to the pandemic. So capacity reporting did prove challenging, and we heard both from THSA and Contexture that there were really several types of challenges that they encountered as they tried to pursue capacity reporting. So first, it was just frankly how to measure these things, right? So it's not, when you talk about things like PPE and bed count, it's not like a bed is a bed is a bed. There are different types of beds. Beds can have different statuses, and we just aren't at a place of maturity where there's clear agreement on how to count. And then that means that when public health gets the numbers without that shared understanding of what they mean, it was hard for public health to consistently interpret the data because they didn't know that there was sort of a standard set of definitions underlying them. Then there were also challenges just extracting the data from the systems because a lot of times the EHR either didn't have a consistent way to represent those data or those data didn't even live in an EHR. And we heard that HIEs just didn't have as much experience connecting with other types of systems beyond EHRs. And so it was hard really just to kind of find and get the data feeds flowing in the same way that, if it was sort of a standard type of clinical data coming out of an EHR. None of these were described as sort of insurmountable, I would say, but just that, when you layered all of the challenges of how do we count this, how do we get the data, and how do we get it to be reported in a way that's understandable, that it just made progress more challenging, especially with high personnel turnover and technical difficulties, limited funding, competing priorities, et cetera. So again, able to make progress. I think each of these problems felt like we have a better understanding of like how to construct the definitions and how to extract the data, but that there was just more foundational work that had to be done, which meant that they couldn't make quite as much progress relative to more mature use cases. Recipients also described that they had hoped to use things like FHIR and API-based reporting, but just found that they were sort of insufficiently mature, especially on the timeline of the STAR HIE program, where the recipients really only had 2 years to make a lot of progress. And so it just felt like it made more sense to fall back on established methods of exchange, traditional HL7 feeds, et cetera. But again, still a lot of interest and excitement in moving towards some of the more novel technical approaches in this space. Next slide. Report and burden reduction was salient for providers, but not realized to the same extent on the PHA side. Again, I think it makes sense if you think about it, for providers, HIE services had that clear, meaningful reduction in reporting burden, but on the public health side, they are still getting data from lots of different sources. And so that sort of, didn't dilute the reporting burden to the same extent. Again, this quote I think is nice, right? ELR from HIE was just a drop in the ocean because we're getting COVID data from everybody. We did appreciate it because it came in more consistently and automatically. But again, it was just sort of one of many inbound sources that we had to deal with, which made the burden reporting less salient, burden reduction less salient. Okay, I'm just going to speed it up because I know we're getting close on time. Next slide. We did not really hear about sort of a single optimal use case for how HIEs can best support public health reporting. Everyone felt that what they worked on under the program was very valuable, but it wasn't like this idea of a killer use case. Like if HIEs did this, it would just be like the one thing that would help public health the most. So it really still is about understanding what the needs are in the local area with your, with the HIEs, public health agencies, and figuring out, what value add services make sense. Next slide. Ongoing sustainability, similarly, it's just shaped by a broad array of factors that influence what services will continue and scale, and some that will actually be sunsetted until a future, they may be needed in the future for a future public health emergency. So we heard about the impact of policies, funding, scalability, right? So they may have designed a solution for one set of EHR vendors, but then they would need to invest to design solutions for the remaining EHR vendors. And just this ongoing perception of urgency. In some states like Texas, they said, well, we have natural disasters, and that's providing an ongoing perception of urgency. Whereas in other states, it really felt like coming out of the pandemic, that perception of urgency had faded. Next slide. It's our last theme. So I think this is the most important takeaway, was that this relatively short and relatively small amount of money investment really was transformative in altering the relationships between public health and HIEs, by providing funding and incentives for these two stakeholders to come together and closely collaborate to advance shared goals, they just strengthened relationships in ways that will be persisting. PHAs talked about gaining this new understanding of HIE capabilities and just interacting more via standing meetings, et cetera. And that what we're now seeing is that public health is coming to HIE to say, hey, here's this new project, can we work on it together? So I think, again, as we think about the goals of the program, this is just one of the key goals that very much we heard was met. Okay, next and last slide. So I hope that this gives you a sense of what we learned from the STAR HIE program in ways that feel relevant to the broader set of HIE efforts that are trying to figure out how they can best support public health needs. Given that the original program tried to seed these 5 different HIEs and make progress, I think it did fulfill its overall goals. HIEs were able to provide more timely and complete data PHAs. They built capabilities to serve public health use cases. And as I said, most importantly, laid the foundation for ongoing future bidirectional HIE PHA collaboration. So we hope that these results give you a taste of what we learned, more to come and more to say about this in depth, but I hope that this was a useful snapshot.
Great, thanks, Dan and Brian. If you guys can please proceed, that'd be wonderful.
Sure. Good afternoon, everybody, and good morning to those further west. My name is Brian Fowler. I oversee public health informatics at the Ohio Department of Health. Just waiting, there's our slides right there. Wanted to just give a brief intro, and then we'll go through just a few slides. Dan Paletti is going to jump in here at the end of what the slides to talk a little bit more from the perspective of the HIE, but I'll just kind of take you through what this project is, where we're at, where we're hoping to go. Just to start out, the idea for this project originally came out of conversations that we were having with the state of West Virginia, is a border state to Ohio, as part of the ideas grant that we got from ASTO. Next slide, please. So through the ideas learning community, and this was talked about at the beginning of the session a little bit, but the ideas community is a project run out of ASTO and funded through ONC about trying to share immunization data and use that data for meaningful things. And there are currently 5 states participating in that project. Ohio, of course, Alaska, Colorado, Vermont, and West Virginia are the others. And we have regular calls to talk about projects like this and what each state is doing to further collaboration between HIEs around the immunization information system space. Next slide, please. Oh, and of course, obviously, I just should mention that the partners for this project, the Ohio Department of Health, which is where I am from, and Dan Paletti from CliniSync, which is our statewide HIE. So why is sharing this data important? It helps improve immunization rates. That's the main thing. We really want clinicians to have access to immunization data. I know in an earlier session, there was some discussion about a survey that showed that clinicians aren't getting the information they need for immunizations in their EHRs. And so we're hoping this type of project is something that can help with that. So we really were looking at, when I mentioned at the beginning that we were talking about sharing data with West Virginia, and the use cases around that were, patients that were being maybe West Virginia residents that were treated in Ohio or vice versa. How do we share that information so that the clinicians in both states that are treating patients that may or may not live in the state that they practice in, how can they get access to that information? And there are, other methodologies for doing this, and what I'm going to share with you in a minute, but we were trying to find something simple that we could do quickly that would get data into the hands of the clinicians. And so what we're trying to do, let me just mention the existing ways that clinicians can access data do include, manual lookup in our immunization registry and data feeds through the promoting interoperability programs. Next slide, please. So what we're doing is the Ohio Department of Health is going to be sharing basically all of our immunization data within our IIS to CliniSync, our HIE, and they are then going to be sharing that data out within Ohio, through their network, but also outside of Ohio through the eHealth Exchange. And Dan will talk about that piece in just a minute. But I want to say we're not done with this project yet. I will say we've gotten through probably the biggest hurdles, which would be getting the legal agreements in place, agreeing to the project, getting it all set up and ready to go. The technical work has yet to be completed. We're just gearing up to get it started, but we do anticipate that it will be done probably in mid-December. That's our goal. And we really do think that this is going to help get some data out into our clinicians' hands that they don't currently have. But obviously, we're going to have to evaluate later when we actually see the data flowing, and we can do some analysis on what value add this project will have. I want to mention too that we're going to continue work and promoting our real-time bidirectional data exchange with providers through the immunization registry here in Ohio. This particular project is really to try to get data into the hands of those people that are not actually doing the bidirectional real-time data exchange. And, you know, it's for those providers that just haven't been able to do that yet. And so this project, may not go on forever if we have, within Ohio anyway, if we have bidirectional exchange set up with everybody. It may be more useful for sharing data across state borders, but right now it's useful for both. Dan, do you want to jump in and talk about the eHealth exchange part of this?
Yeah, thanks, Brian, and good afternoon, everybody. We're really lucky in Ohio to have such a great group at the Department of Health working on the immunization side of things. And as Brian mentioned, we want ODH to continue to be the source of truth for immunizations, and we are work with them hand in hand to really create that bidirectional exchange with providers who might need some assistance. And we want that connection to be directly with ImpactSys. So that's work that we will continue to support. As Brian mentioned, for those providers, we have a lot of small practices in Appalachia and in rural parts of Ohio and across the state that didn't have great access. So by getting access to the ImpactSys data from ODH, CliniSync will be incorporating that data with the rest of the immunization data in a consolidated CCDA that we will respond back through the eHealth exchange. Primarily, again, this was with the folks in West Virginia is where kind of how this started to, we have so many people going across the river for care. This will give access to those West Virginia providers to any immunization data and other data. That is up and that eHealth exchange part is up and running. So all we have to do is add the immunization data to it. And the other thing we think will be helpful too is, we have a large number of FQHCs in the state that manage a huge portion of our 3.4 million Medicaid lives in the state. And, really being able to potentially focus on immunization gaps, for kids that have gaps in immunizations because of COVID and just, the ongoing need to better support that work. We think there's a lot of things that could come out of this. So, we're pretty excited about being able to make that information available across borders. Again, as Brian mentioned, to some providers that don't have great access, but again, really just trying to continue the direct bidirectional exchange with ImpactSys is really critical to long-term success. So happy to answer more questions, but I wanted to kind of leave a little time if there are any questions in the chat or from the group. And Brian, I don't know if there's anything else you want to add there.
No, I think that's it from Ohio here, unless there are questions.
Hi, this is Vishali. It looks like, we have maybe a couple of minutes before the break. And there are two questions in the Q&A related to the presentation you gave. One question is, did you consider using the IZ Gateway to share the IIS data with other states? So maybe we'll start off with that question and then get to the next one.
Yeah, that's another methodology that we're hoping to use. So this is, we're trying different things. And when we looked at different options for things, this was the quickest, easiest thing for us to do to share data with West Virginia. And so that's why we went with this. But we are participating in other things as well. Yes, thank you.
Right. And then another question, are local public health agencies able to access the data through this mechanism, or what other mechanisms might, be available to them?
Yeah, so if the local public health agency is connected up with CliniSync, our HIE, then yes, they could get it that way, but they can also access it through our immunization registry, either by logging in or getting data through it that way.
Great. If we can get, there's a question from Michelle, if we can get her on board here. Michelle, question from Chris from Washington State. We are not able to get our healthcare organizations to expose an endpoint to send the result back to. So we are struggling a bit on how to notify them that their result is ready. So I don't know, Michelle, if you're able to answer that question.
Yeah, I can. I think this is, Chris, we could have a conversation with this. I do think that what we have been doing is focusing, like I said in my presentation, focusing on working with the EHR vendors and working with them to support their partners in actually developing these different connections. Because it has been very difficult in the past, and that's why we ramped up this initiative, because a lot of people have been running into the same issues. So what we've had to do is to engage with the Epics and the Cerners of the world, Oracle of the world, to really think through how we can create a version-based endpoints with the EHR vendor for their clients. So it's really important to think about who can do this work with you and for you, and who can actually kind of force that change. But happy to talk more about this. I mean, we are in the thick of it right now, and it's definitely not easy, but please reach out.
Great. And Julia, if we could get Julia in the mix here too. Hey, I know we are at time for, our scheduled break, but if there are any burning questions for the group, definitely you can reach out to me. Certainly I'll put my email on the chat, and then I can route any questions to the group here. And I really wanted to thank Brian, Dan, Michelle, and Julia for really sharing how networks have really, upped their game, to address some of the needs that have been brought to light in the pandemic. So, anyway, thank you all, and please return back from the break for our second half. Next slide. I think I have the, at 1:30 to enjoy the second half of today's workshop. And tomorrow there's also another day of the workshop to learn more. So thank you, everybody.
Great. Good afternoon, everyone. Thank you so much for joining us for our second half of the day. We're super excited to be here. We're going to be specifically focusing on a couple of to provide their perspective on some of their work as it relates to moving forward around data modernizing, especially specific to describing their successes, their challenges, their lessons learned around modernizing their data systems. So our first presenters are Dawn Nims, who is the data manager and epidemiologist for the Illinois Department of Public Health Communicable Disease Program. And along with her is Megan Patel, who is a surveillance and informatics epidemiologist within the communicable disease section at the Illinois Department of Public Health. So we're super excited to have them. Second, we have, so Sarah is the manager of the Minnesota Electronic Disease Surveillance System, or MEDS, at the Minnesota Department of Health, and the co-lead for the data modernization initiatives at the agency. She is joined by Dave Johnson, who is who has experience working in public health at the county and city level. He currently serves as the epidemiologist, informatics, and immunization manager at the Hennepin County Department of Public Health. And then lastly, we have Benjamin Schramm, who began working as the surveillance system manager at the North Dakota Department of Health and Human Services. So in his role, he manages the North Dakota Electronic Surveillance System, MAVEN, which is variable conditions, data feeds, supervises surveillance and data quality programs, and engages in many data modernization initiatives. So I'm very pleased to have this well-esteemed group of folks present. So I'm going to pass it off to Dawn and Megan to kick us off.
Hello, thank you, Rachel, for the introduction. Again, my name is Dawn Nims, and I have Megan Patel with me. And we're going to review how linkage between our vital record system and our surveillance system work, as well as discuss the implementation of business rules that we've developed, all in which have improved our mortality surveillance and reporting in Illinois. So next slide. So infectious disease mortality tracking and reporting can be challenging and time consuming. So many times a reportable infectious disease is reported, investigated, control measures implemented, and then the case is closed. This process can take a day or two, up to multiple weeks, depending on the condition or circumstances. And many times follow-up after the initial investigation, once the case is closed, is not done or even needed. And so sometimes we don't know those outcomes. You know, did the person survive? Did they have long-term issues and things like that? So in order to capture and identify persons who have died due to these consequences or reportable infectious diseases, us at IDPH, we've developed an automated process to help import vital records death certificate data into our surveillance system, where details on the deaths are logged within our reporting system, so we can do some additional analysis and investigation. This is a two-part process that I'll go more in depth in the next few slides. Next slide. But before I go into how this process works, here are the details of the two applications that are used in this process. So INED stands for the Illinois National Electronic System. Surveillance system. It was developed in 2005. It's a homegrown Java-based person and event hybrid model, meaning there's a unique person account for those with reportable infectious diseases. And under those person accounts, you will find each individual reportable condition or event associated with that person. And then there's IVRS, that's our Illinois Vital Record System. This was developed in 2008, which acts both as our electronic vital record system for births and deaths. Next slide. I just wanted to provide a visual of our surveillance system. In particular, this is what you would see when you're looking at a person account. So here we've conducted a person search. And so underneath that person account, when you look, for first name, last name, date of birth, you'll see each disease or case report that's associated with that person. So if you click on one of those disease names, it will take you into that unique case report under that person. Each of these case reports has a unique case ID or state case number. You could also search for by state, go direct specific and for that person. I just wanted to kind of show you what that looks like. So next slide. So to explain how this integration and import process works, like I mentioned, it's a two-part process. So part one is shown here. So this is what we would call our person match. This matches all person accounts in our surveillance system with deaths reported in our surveillance system. So like I said, a person match. This process runs daily at 3 a.m. It pulls a list of persons out of our vital record system that have been deceased within the past 30 days. And a match is conducted against all person accounts in our surveillance system using a database script written in AQT software. And it's a match looking at exact first name, last name, date of birth, and gender. If a match is found, it updates the person account with deceased equals yes, and then the date of death, and then sometimes even the location. Our reporting database on the back end is also updated with this information along with all certificate. So then we can in turn query and run reports off of that data, which I'll show you a little bit later. Next slide. The second piece of this integration or update looks at the vital records death certificate for any reportable condition that was listed or any keywords as cause or contributors to the death. So these terms are matched as wildcard terms against the literal causes of death fields on the death certificate. So there are 5 total fields. There's the immediate cause of death, there's multiple consequence fields, and then there's other significant conditions that contributed to the death. So each night, a tilde delimited flat file is produced with these death certificates that contain deaths that match a notable reportable infectious disease from our external list, and that's imported into our surveillance system as a death report. So then this report can either attach to an existing case, it goes into a queue for that specific disease that was on the death certificate. If we have a case to that case, merge it together. But if there is no case, we can create a new one, a new person account, a new case, and then we will initiate an investigation based upon that death. Okay, next slide. I just wanted to kind of show you an example of the disease match against the cause of death queries that we utilize. And so the disease key is a key for the specific disease within our surveillance system. So it's a key that we use. And then the disease name field is the actual disease name or keyword or acronym, that we use in that wildcard search to do that match. So you can see this is actually a work in progress still, even though we've been doing this for quite a while. You can see, the multiple different names for COVID and coronavirus that we use on death certificates. And I think monkeypox is there and so on. So that's just to kind of give you an example how we do some of that matching. Next slide. So when a match is conducted and a case is updated with the death certificate, the case report in a person account will be updated. So depending on the match type, the logs will look a bit different. However, it will always indicate that there is an IVRS log. So users know that some of the information in this record was updated from the vital record system. So there was some sort of match that was conducted. When a death certificate comes in with the actual reportable infectious disease listed, so that specific death certificate report is merged into that case, it comes in separately. And then when this happens, the logs update noting that there was an IVRS disease match to that particular condition. So that's what's highlighted in the slide here. If there was simply a person match, meaning that, hey, we found the person in the system, they're deceased, they updated deceased yes, and the deceased date, that's what the logs would look like below. And it would not indicate that, hey, we noticed that there was a disease match on this case report. Next slide. This is just showing some additional information that's returned from vital record or surveillance investigations. We utilize this data for follow-up and determination of the death. We also get some really good demographic information like race, ethnicity, any address information we may be missing. Next slide. And then this is just an example of what our demographic page looks like within our surveillance system. So all the highlighted fields is potential things we can find within the death certificate that we may not have. This page is stagnant across the conditions of the person account. The at onset fields do keep. So, you know, at times people do move and have different addresses. If we have multiple cases, those will stick with the case, but we're able to update those and then, you know, keep a historical record, and everything on the demographic page can be updated. Next slide. If there's a disease condition specific match where the death certificate's merged into the case, this additional information will merge to the case as well. This is also really helpful. Data information on who to follow up with regarding the death. So it provides the place of death. Sometimes it's a hospital, sometimes it's a long-term care facility. We also get the certifier or physician of the death certificate to follow up with as well. Next slide. In addition to updates within the case record, our reporting database, as I mentioned, is also updated with all the causes of death. So this is an example of a QA report that we're able to run out of our reporting system. So as you can see, we're able to connect our case record data to the data found in the death certificate in order to determine if the death was, you know, due to or caused from a contributor of the death. We could also analyze other data such as time frame from onset to death. We also could look for, you know, age and query out pediatric deaths and things like that. So the reporting is very useful. Next slide. When deaths are updated on our surveillance system, I mentioned it gets updated on the demographic page, which is our general page. So the deceased update state is then updated for that. However, this does not mean that a person's death was attributed to that case. So if someone has a hepatitis B case and a COVID case, just because they're deceased, it doesn't mean that hepatitis B and COVID was the cause. So in order to determine if the death was due to either the condition, additional investigation needs to be done. And then we will update a secondary question within our surveillance system that's for that particular disease case report. If the patient died, did they die from the disease or a complication? This is a manual process, and it's up to the investigator to update this question. Fortunately, it's not always done, so we are able to perform QA with reports like the previous slide, like you saw, that we could go back and update this field. Okay, next slide. Like I mentioned, that's a manual process. It's not always done. And so we've developed business rules around this. So in 2019, we conducted prospective analysis system and found that 94% of our infectious disease-related deaths occurred within 30 days of their onset. So with these findings, we decided to implement business rules within our INEDS, our disease surveillance system, that will force an investigator to review a confirmed or probable case if the case is marked deceased and the death was in 30 days. So on the left-hand side, you could see there if the report is closed and completed, and then an IVRS match was done after it was closed. If the death was within 30 days of the onset, so we'll do a date comparison, that case will reopen for the investigator to follow up and then determine if the death was due to the infection or not. And then if the case report is open and there's either an IVRS death match or the deceased field can be updated manually, an investigator or provider can go in and do that. If the death was in 30 days, the case report would not be able to be closed and finalized until that secondary question is. Next. So although this process that our team has developed is pretty great, it does come with some identified issues and areas of needed improvements. At times, our deaths are not reported timely in IVRS or finalized. So if they are delayed past the 30 days, the match does not occur and the death won't be pulled into the surveillance system. And this also includes for any updates or addendums to death certificates. Those don't automatically come in. We don't know about those. Sometimes keywords or terms are missing from our list, so they get missed from time to time. And then we'll have to do, you know, the other QA. And then additionally, we've also found issues with some of our key terms and wildcard searches that we maybe made too broad. And so this is one that we actually just saw this past week. It was a listeria case. We have our disease name as listeria there, and it picked up blistering skin lesions from the death certificate, and it pulled it in. It looked like a listeria death. And so the investigator noticed, hey, something doesn't look here, and they did. So when we certificate, we realized, oh yeah, that shouldn't have matched. And so another issue that we've identified is at times the death certificates are matched to the wrong person because this is a first name, last name, date of birth, gender. Yeah, that's pretty specific criteria, but with common names, we do find, that this gets matched with people in our surveillance system, especially with all the COVID cases. We have a lot of cases now and person accounts. And so, maybe we need to implement a better match system, maybe looking at dates, onset dates and deceased dates and things like that. So just some issues to note. Next slide. But overall, automating the ingestion of our vital records, death certificate data, and implementation of our business rules have increased our timeliness and completeness of our infectious disease mortality data. It was particularly useful and aided in the mortality reporting and accuracy of our COVID-19 deaths. As you know, early on in the pandemic, and report out COVID-19 deaths. So this process not only allowed for us to quickly report the deaths as they were coming in, but it also allowed us to feel confident that we're reporting deaths accurately and vetting out the non-COVID related deaths. As well as able to follow up, make sure it matched our death definition, because we were able to review not only the death certificates, we were able to couple it with the surveillance findings, all in one report in one system. Okay. Next slide. At the end, I just wanted to acknowledge Megan Patel and some of our technical team. And that's all I have.
Great. Thank you so much, Dawn. We really appreciate it. So moving on to our next presenters from Minnesota. So I think, Sarah, you might be kicking it off.
Yes, thank you. Hi, everyone. So today we'll be talking about a fire project that we're doing here at the state of Minnesota in conjunction with a local public health jurisdiction, Hennepin County, that we're doing as a pilot. Next slide, please. Okay, thank you. Okay, so for those who aren't aware, FHIR is Fast Healthcare Interoperability Resource, and it's sort of the next generation standard for data interoperability and exchanges for healthcare data. And it's really gained a lot of momentum kind of in the clinical setting. And so this was our chance to continue to kind of expand that standard within the agency here. And so we were trying to kind of tie that with, just our ongoing challenges of interoperability within the public health system. We've made a lot of gains during the COVID years, but there's still definitely room for us to improve. And so we were very interested in kind of seeking out and in finding new use cases for FHIR to implement and expand our use of it. And so MDH is working as a pilot with the Public Health FHIR Implementation Collaborative in order to do this work, and specifically looking at FHIR use case that benefited both state and local public health agencies. Next slide, please. So as we initiated this work as part of the collaborative, we were able to partner with the folks at MITRE who really helped facilitate and manage a lot of these early discussions about our use case and our pilot. And they also provided a lot of educational opportunities and support with the FHIR standard, as this was, a newer technology and concept for a lot of the staff working on this project. So the MITRE folks were very integral in the success in this moving forward. So our Office of Data Strategy and Interoperability really initiated this pilot project with the collaborative. And as we were going through, we quickly identified Hennepin County as our recruited local public health agency to partner with based on interest and also capacity at the local level to kind of do this type of work. And so we formed a project team comprised of our data strategy and interoperability staff, our Minute staff, which is our centralized IT staff here at the state, our meds operations unit, which is the team that works in our electronic disease surveillance system, our STI program EPIs, and then leads from Hennepin County, and again, those supporting staff from MITRE. And so as we kind of took on this project, we did a structured methodology led by MITRE to identify the feasibility of our data exchange and to select a use case. Next slide, please. So coming into this project, some of our anticipated values is that this was really going to build our fire skills and knowledge within the state and the local jurisdiction so that we could reproduce this and expand and scale it in the future. And not only was this fire skill and knowledge for our IT staff, but it was also for our programs and informatics staff involved in the project. We really wanted to also use the opportunity to do some relationship building between state and local jurisdictions to identify future use cases for fire. And then again, to just identify the key staff and skills needed for this process and for us to be successful in future fire developments. And ultimately to expand fire capacity at MDH. We had already started some fire projects with our Office of Vital Records, and so we saw this as a great opportunity to expand beyond that. Next slide, please. So in working through that kind of structured methodology to select a use case, we went through various criteria. So again, we wanted to focus with data exchanges for Hennepin County and ones that would be beneficial for both parties. And so one of the key things that we focused on was looking at an outbound use case of data. The reason behind this is in Minnesota, we're a centralized disease reporting agency. So that means that that information typically comes to the state first and then goes out to the local jurisdictions. So we wanted to pick something that would really highlight that. And we also wanted to kind of make sure that we had some interoperability needs that weren't being met presently. So as we looked at potential use cases, we came up with something to do with infectious disease case management, vital records, or immunization data. And as we talked through those data sets, ultimately we decided on infectious disease was the highest need for this type of data exchange. Hennepin County was already able to get immunization data from us through a bulk query, and our vital records group was already engaged in some other fire projects. And so we quickly identified a syphilis case report and data exchange that was happening presently with the county that we identified as one that could stand to be automated and was a great candidate for our fire implementation. And we already had data use agreements and things like that on the book with Hennepin County for this as well. So that was another kind of step or barrier in the process that we didn't need to worry about because those were already well established. Next slide, please. So with our fire pilot and using syphilis data going from our electronic disease surveillance system to Hennepin County for the purposes of supporting their case investigation and follow-up. And so just a little bit more about that. So Hennepin County includes the city of Minneapolis and has about 22% of the state's overall population. And during this time, a lot of our syphilis new infections and sometimes subsequent outbreaks were really focused in the Twin Cities metropolitan area. And so Hennepin, was a great candidate for this, and syphilis as specifically, because during the time frame that we were looking at some of this, we saw that our syphilis cases had increased by 33%. In recent years. And so that was a key reason why we selected syphilis for this work. Next slide, please. So our med system is kind of the source of the data. And again, it's our electronic disease surveillance system. It's our integrated platform. It's a person-centric system that we are able to do case management, contact tracing, outbreak investigations, and it also is where all of our electronic laboratory reporting data flows to, and our electronic case reporting data. So by setting up these exchanges, we're really kind of creating potential for a future one-stop shop when it comes to exchanging case data and follow-up measures. Next slide, please. So a little bit about the data process flow and the architecture that we have in place for this. So the MEDS application currently has its own data lake. We are cloud hosted. And so data from our MEDS production system gets copied down and moved into our data lake 4 times a day. And then from that data lake, we are able to develop views to really kind of capture the data that we needed to exchange with Hennepin County to mimic a report and a data exchange process that was occurring manually between our EPI program staff and case management staff at the county. And so in that view, we're doing filtering, not only kind of constraining based on what syphilis cases and event data are to be shared, but then there are also access controls built within the API layer, such that when Hennepin sends us a query message, that their profile is also restricted to only returning things back that are for Hennepin County. And so that view really becomes integral in this overall process flow. And again, we have our FHIR API established with Hennepin County, where they can send and receive those query and response messages through kind of our MDH gateway. Next slide, please. So as we are moving forward in this process, we have much of it developed already. Right now, we're kind of in the step of doing some Q&A and data validity testing on the MDH side before we start sending things over to Hennepin. But as we're looking at this, really it took a cross-disciplinary team to make it happen. There are a lot of different moving pieces and people that needed to be in place in order to get the project off the ground and moving. And so with that, it was quickly determined how critical our communication and coordination was. So from our Office of Data Strategy and Interoperability, we had resources for project management, for our contract management and financial resources. Our syphilis program staff were the SMEs for the data set and the filtering that needed to occur to have that data exchanged with the county. Our MEDS operations informatics staff did a lot of the heavy lifting with the data mapping, creating that filter logic into specifications for the IT teams to build out into our data lakes and views, doing testing and documentation as well. The IT teams who worked together in conjunction with the MITRE folks to kind of develop the overall design, the FHIR API, the user access controls, and all of the elements around the data lakes. Of course, our partners at Hennepin County, program staff, as well as technical staff on their end to be able to send these FHIR query and response messages and receive the data into their systems. And again, the MITRE team really helping us from a technical assistance standpoint, training and consultations. Next slide, please. So some lessons learned from the project already. The big thing here is that data flow process and the mapping. And so we really kind of highlighted that having that process down at the beginning of the project is really beneficial. And that includes that data filtering part of it, and making sure that we're kind of capturing all of the data translations and transformations at each juncture and handoff of the process. Another big thing that we learned was really it was key to find the right people, especially after the COVID response, where a lot of people were still kind of disparate or had a lot of projects on their plate, maybe had some COVID fatigue, as we like to call it. And so we really had to make sure that we were right sizing the project team and making sure that we had the right people on board. And so again, with that, the communication and documentation is really key, as we have so many different teams involved and handoffs needing to be made in order to make the project a success. We also needed to develop folks who understood the fire standard as well as the data that we were trying to work with. And so that training upfront became really critical. And because of that, we needed to make sure that we had both IT and program staff kind of on that same level. And then kind of getting back to the staffing resources, competing priorities with key IT staff really became something that we needed to work through. As I mentioned earlier, Office of Vital Records was already having a fire project engaged. And so we needed to work with them in order to make sure that both projects weren't impacted by work of the other. Next slide, please. So as we look kind of into the future with fire, some of the things that we're really looking at, again, the key thing would be the staffing. So we need to build capacity within our agency for, skills on fire, making sure those staff are available and setting expectations and trying to mitigate things like burnout and turnover at the agency. We need to make sure that any future fire projects align with our overall data vision and roadmap and our DMI initiatives. We need to be coordinating with our partners and figuring out what their asks are of our data and how we can exchange with them. And we need to be thinking about that as well through a health equity lens. And really trying to, create areas for the technology to help us with some outdated or clunky processes as we go forward. Next slide, please. So next step with this specific project with Hennepin County and the syphilis data. So our phase 2, we're going to be looking at doing some bidirectional fire exchanges with Hennepin so that we can kind of get some syphilis case data back from them. And then we're also, as we finish out phase 1 and sit and evaluate our minimum viable product from that work, we want to really document some lessons learned and implement them in any of our future fire implementations, look to make enhancements in our infrastructure and the design to really make sure that it is scalable and reproducible for other endeavors. Next slide, please. All right, thank you for your time.
Hi, if we could move to the next. Oh, I see David is next, sorry.
Hey everyone, good morning or afternoon, depending on where you're joining us from here at this virtual learning session. I'm Dave Johnson. I am the Epidemiology and Informatics Manager here at Hennepin County Public Health. And if you could go to the next slide. Just going to follow up with the local context at the county level, following up on Sarah's presentation on the state level. Sarah talked some about this. Our public health context for this project was really looking at the large increases in infectious diseases, particularly in syphilis in our jurisdiction, since the mid-2010s and into the 2020s here. Our syphilis cases have increased by 31% between 2021 and 2022. We also have a large portion of those cases that are known to be people experiencing homelessness, and many of those are served by our county healthcare for the homeless program, where we were seeing increases in cases as well. We know from looking at our surveillance data that 34% of cases have a history of receiving housing services, and 14% of those cases have a patient history with our healthcare for the homeless program. Next slide. And so really we see data as being the cornerstone and key to our local response efforts. One key way that we use data at the local level is to support our follow-up activities. And so we cross-reference our data against our public health patient list, look at human services and our homeless information systems to help get a sense of where people are within our service continuum, and then try to help coordinate treatment and follow-up. Local data also are very important for us to allow for disease surveillance and break down information by demographic factors such as gender, gender, age, and race ethnicity. Excuse me. And so really getting that information helps drive our understanding of populations who are at risk and need additional attention within the county. Next slide, please. And so the original state that we were working with was that, as Sarah said, we had a data sharing process in place. That process, however, relied on staff processes to extract, format, and upload case data through SFPT drive at the state level. And then our epidemiology staff manually downloaded that data and transformed it and modified it to be able to read into our system. And that system was something that took place on a monthly basis. Next slide. So some of the limitations that we identified were that having data only monthly hinders timely follow-up. Ideally, we'd like to get data more frequently than that. There's also staff time required in data preparation and manipulation. And then also because we had a human factors in the process, those can create delays if people are taking vacation or there are competing priorities. That can lead to delays in data being updated. Next slide, please. And so one of the things that we were really able to leverage at the local level is that at the same time that we were entering conversations with the State Health Department and MITRE about this project, we were also embarking on some data modernization internally. Following up on COVID, we had additional resources from the American Reinvestment Act that allowed us to stand up a data engineering unit called our Public Health Informatics unit. This unit was new as of March 2022 and fully staffed since June of 2022. And one of the main features of this modernization is that the staff in this unit developed an Azure data lake to house our vital statistics, infectious disease surveillance, and other public health data systems. Next slide, please. And so these modernized data systems allow us to leverage the infrastructure, which enables us to produce interactive reporting in real time that can utilize the data that are in the data lake. And so this is an example of a report of a surveillance report that we update on a regular basis in order to look at the characteristics of the syphilis outbreak ongoing in our community. Next slide, please. So the anticipated outcomes of this fire collaboration is that we could query a state fire server for syphilis data based on the date range. We could ingest that data into our public health data lake. We can match that data against public health, clinical, and housing services to examine opportunities to assist with case follow-up, and that we'd be able to populate data into our Power BI surveillance reports. Next slide. And our progress to date is that we have developed an API call function using Databricks that allows us to interact with the state server. We've done some small-scale testing of API response and have been working to assure that data are received accurately and in the expected format that we can use for internal data analysis. And we are preparing for final user acceptance testing and production deployment of this system. Next slide. So our next steps are to move toward production and complete user acceptance testing. We hope to evaluate what process improvements we see from the business perspective in terms of hoping to reduce staff time and increase or decrease lags in having data that are updated. And then as Sarah mentioned, we have a phase 2 of this project where we're exploring bidirectional data exchange to return information that we have on cases for the state health department. Next slide. So the lessons that have been learned at our end is really that local public health data systems require additional investments to enable interoperable data. I would say that having our informatics unit in place and growing at this time really was important to making this project possible at the local level. Migrating our data storage solutions to cloud-based infrastructure created a flexible and responsive ecosystem to nurture the project. And we found that staff skill in creating these data pipelines has grown through the exposure to fire data transfer. Next slide. Then that's the end of my presentation. Here's my contact information and I can take any questions.
Great. Thank you so much, David. Really appreciate it. Thank you, Sarah. So moving on to our last presentation, Benjamin.
Thank you. I'd like to share a little bit about our process for automating our data and reporting in North Dakota. If we could go to the next slide. I want to take a look quick at kind of where we started. We made a lot of progress due to and throughout the pandemic. Basically, the pandemic forced a shift in how we thought about handling our data and reporting. Usually before the pandemic, we retrieved data on kind of an as-needed basis, just using it to monitor our cases, publish one-off reports. We didn't really have any, or we had very minimal linkages between data systems. That obviously didn't work during the pandemic, where we needed to have quick, consistent, reliable access to data across all of our different data sources. We also found that we had many more people involved in viewing and interpreting that data than ever before, and also suffered a little bit with lower quality data than ever before, with a higher quantity and more staff working in that data. So we really had to rethink how we managed our data. One of the things that we had previously been used to was, if we had the question of how many hospitalizations are there right now for this condition, we would just check a report in our surveillance system and report on that. But with the rapid change during the pandemic and the need for rapid data, we found that that question would be asked again a couple hours later, and we'd have a different answer, and that caused a lot of confusion. So we couldn't really assume anymore that the people analyzing our data would understand the limitations, couldn't ensure that it was being used properly, and there was just a larger separation between collection and analysis. So if we look at the next slide, kind of shows where we started, extracting data from any of a variety of systems, processing the data independently. Nobody's using the same source of data at the same time. Things were confusing. So if we go to our next slide, we can kind of see the steps that we made. First were to create a single source of truth. If we go to the next slide. First step that we did was to create a single source of truth for all of our data needs in a day. That was really critical to being able to make sure that no matter who was asked a question, it was going to be answered the same way. From there, we moved on to automating our processing, serving the data, and reporting the data automatically. If you go to the next slide. So in order to create that single source of truth, we chose to freeze our data every day at midnight. That ensured that we had every update from the day before in our data. We had people who were responsible for cleaning our data up until that data freeze, and then once it was freezed, that would be used for every single report the next day. It was a difficult step for a lot of our team. Most of our epidemiologists were used to being able to extract real-time data from our systems. But with the reduced confusion and just overall improvement in the availability of data and timeliness of data, it was pretty quick to get people to move over to using this kind of single source of truth. If we go to our next slide. So that was a big change, but it was incremental. We still had many of our critical epidemiologists spending hours overnight on top of their already long days preparing that data. And although we had a source of truth, we were rapidly going into the realm of burnout. So if you go to the next slide, we next moved to replacing that significant human effort overnight with a automated processing pipeline. We added to that pipeline kind of piece by piece. First, we started by targeting our outputs, looking at the specific reports or data sets that required the most manual effort. Then we looked at replacing what was starting to become very time-consuming data extracts with direct queries directly out of our surveillance systems database. If we go to the next slide, we can see our slightly improved process here. We replaced that large amount of that human element. We've got a data processing pipeline. However, we still had fewer people, but we still had people who were responsible for monitoring that for errors, making sure that it started on time, and so on. So we still needed to do better. If we go to our next step, next slide, this was probably our largest step and the thing that I think has had our biggest impact over time, was working with our North Dakota Information Technology Department, NDIT. We worked with them to build a data warehouse to store all of our COVID-19 data. That warehouse was configured to automatically update all of our data sources at midnight. It then created all of our connections between data sources, cleaned, validated the data, served it up to end users. So really replaced all of those processes that we were doing overnight with standardized ETL processes that occurred on servers with error handling, and just a much better process. If we go to our next slide, then the final step was to automatically report. So we connected those data warehouses to the Microsoft Power Platform, to data flows. The majority of our dashboards and reports that we use here in North Dakota use Power BI. And so this was kind of critical to being able to seamlessly automate that final process of getting our data exported, cleaning it, and then reporting it. Once we connected our data flows in the Power Platform to the data warehouse, it essentially allowed us to select a refresh time. I think we chose 10 a.m. every day, and that data was automatically refreshed. And really, unless there was a major issue or error, that was largely hands off. It really allowed us to step back and even take days or nights off. We implemented this process right before Christmas 2020. And so that was essentially a way for us to be able to enjoy our holidays a little bit and take a day off. We move forward a lot from there. Outside of the Power Platform, because we did have the data available in our data warehouse and views built on that data, those who weren't using Power BI were also able to fetch the data from the data warehouse. One thing that I did with this was to send emails and texts to select staff containing reports or data quality monitoring or workflows. If we go to the next slide, This kind of just shows that final overview of the process with our ETL process. We still do have that Python processing pipeline in there. In an ideal world, we would have probably removed that. But with how fast changes were being made to guidance, we decided to make sure we kept that in, so we had the ability to refine some of our reporting and the data that was in our warehouse without needing to go through the interagency work with our IT department, where things tended to get slowed down. If we go to the final slide here, where are we at today? So outside of a pandemic emergency, it's much more difficult to get those IT resources that we needed to be able to expand our data warehousing. We are slowly and surely building into our data lake and building data warehouses on that. But it is a slow process with fewer resources available to us. Because of that, we are often using alternative methods that really are inspired by this model. We found that our surveillance system, we can kind of skip that data warehousing process and connect our database directly from our surveillance system into Power BI, into those data flows, and still are able to create data sets that are frozen at a certain point in time. So we've got that single source of truth. We also are able to then create reports and dashboards that are able to refresh on a daily or weekly or similar basis. I guess the final thing or lesson learned here is just that we've had a shift in expectations of how we report our data. Prior to the pandemic and prior to what we built here, it was more about just getting data reported, regardless of how much time it may have taken. And we really, from the start now, try to look at, how can we make sure that when we create this time-intensive process, how can we turn that into an automated process once we get the, the testing and the quality control figured out. And that is all for me. Thank you.
Great. Thank you so much, Ben. We really appreciate it. So we just have a few minutes here. We can address some questions that have kind of come in the chat as well as the Q&A. I'm going to go back to Dawn and ask Dawn, so this person, like the public health data exchange modernization, like include patient data sourced from remote healthcare facilities, and who is verifying and validating that data? I don't know if Dawn's still on.
Yeah,
Maybe.
I'm still here. Yeah.
Okay,
So our data comes strictly from our vital record system. So our data, we're looking at cases that are in our surveillance system that were sent to us either through, ELR or provider reporting and things of that sort, and it's matched with actual death certificates from our vital records system. I don't know if answering this question, the vital records, those are finalized death certificates, so they're validated through there. So I'm not sure if that answers your question.
I think that answers the question.
Yeah.
If not, feel free to submit some clarifying information. I did see something in the Q&A about fire and some of the pieces that Minnesota is kind of like looking at as it regards to in your experience in working with fire, both in Hennepin as in Minnesota, was it like what you anticipated? Did it allow you to utilize the data better and it's more modular. I think that would be good to better understand that piece. I don't know if David or Sarah want to expand on that.
I mean, so I can take a stab at that. So, I mean, we haven't fully implemented the data exchange yet, so it's hard to know exactly what the benefits will be. But I think that the hope is that by building these interoperable systems, there will be a significant improvement in data lag, and we will be able to follow up with cases on a more quickly clinically to get people quicker access to treatment. I don't know if that helped answer the question.
Yeah, and I think something, you know, again, it's hard to comment on something that isn't actually in production yet. But I think, you know, as we're exploring this project and looking at the data that we are exchanging with Hennepin, you know, it's leading to some really good conversations about what are the data needs versus what historically have we given the county, you know. So it's been a really good touch point to really talk about what is the need, and how can we expand upon that. And I think as we've worked with the project team, some of the flexibility with FHIR in order to kind of structure those response messages, to have some things built out so that, you know, we use some of our local codes that are, you know, within our own jurisdiction, our own surveillance system, and how we're operating and doing case management and follow-up, have enabled us to do that, as opposed to just following a really strict and confined structure where, you know, if there's not a spot for that data, that it's not something that we can share. So having that flexibility, I think, has been really vital in building this out and making it a meaningful exchange of data.
Great. Thank you. Thanks, Sarah and David. So I had a question for all of you. I know Benjamin talked a little bit about how the IT is structured in your health department. And I know that some have it centralized, some have it decentralized. So I'm curious as to, you know, Benjamin talked about some of the issues that he faced in regards to that. And I don't know if, you know, Dawn or Sarah or David could, you know, talk about like some of those challenges in working with those folks.
Sure, I can speak to that a bit from the state of Minnesota perspective. Our IT is its own centralized agency, but they have staff who are then deployed to other state agencies. So we have a minute group at the health department, and then from there they are either pooled resources or dedicated resources depending on funding and the nature of their position. So for our electronic disease surveillance system, we're fortunate enough to have the funding such that we have dedicated IT staff that only work on that particular application. Our data lake and other developers, those are from sort of a shared resource pool. And so we do have to work to ensure that we get their time and availability when we're working on projects such as this. So really demonstrating what the need is, what the importance is, goes a long way in garnering and making sure that we have those resources available to us. So, you know, having so many people behind this project. So, you know, the infectious disease group, our Office of Data Strategy and Interoperability, knowing that we were serving as a pilot group, you know, made it easier to obtain those resources, but it wasn't without challenges because we had another conflicting pilot project that was going on with our Office of Vital Records. So, you know, there's always going to be kind of that push and pull for these key resources.
That's awesome. That's super helpful, Sarah. Thank you so much. And again, I just want to say thank you to all of our panelists here for a great presentation about some of the challenges, the strengths and challenges as it relates to some of your work forward to modernize your. So with that, I'm going to hand it over to my colleague, Molly Murray, who is going to moderate our next panel.
Thanks so much, Rachel. Really appreciate it. And thanks everyone for sticking with us through the rest of the day and for our final session. So from 2:30 to 3:30 Eastern, we'll be hearing from Mike Berry with HLN, Theron Jepson with EpiTrax, and Jim Daniel from Amazon Web Services. This presentation is on advancing public health interoperability from a vendor perspective. As we've heard from many of our great presenters already today, public health departments are making significant strides in transitioning to the cloud and implementing new ways for streamlining data ingestion. So today we'll hear from this panel about some new approaches that technology vendors are implementing for public health and where the industry is headed to support public health interoperability. First, we'll hear from Mike Berry, who has staffed and managed health information system projects for HLN Consulting in several states, as well as at the national level. His work is focused on public health registries, connecting public health and health information exchanges, standards-based messaging and interoperability architecture, privacy and security in HIEs, and person matching technologies for integrated systems. Next, we'll hear from Theron Jepson, who has worked in public health at the Utah Department of Health and Human Services for the last 19+ years, 10 of which have been in public health informatics. In addition to working in public health informatics, Theron has also worked in injury prevention and infectious disease as a health educator and an epidemiologist. He currently serves as the assistant program manager for the Division of Population Health Informatics program at the Utah Department of Health and Human Services. And last, today we'll hear from Jim Daniel. He's the public health leader for Amazon Web Services state and local government team. As that public health leader, Jim helps state and local health departments, as well as government-owned providers and HIEs modernize their health IT infrastructure to help improve health outcomes. Prior to joining AWS, Jim served for almost a decade with the United States Department of Health and Human Services, where he promoted public health innovation, including development of the Immunization Gateway and consumer access to immunization information systems. He also led the efforts for state and local health departments to receive data from electronic health records as part of the high-tech program and the massive transition of healthcare providers from paper to electronic records. Before joining the federal government, Jim was the CIO for the Massachusetts Department of Public Health and also holds an adjunct position in drug regulatory affairs with the Massachusetts College of Pharmacy and Health Services. So thanks so much for all of our excellent presenters, and I will pass it to Mike, who I believe is first on our docket for this conversation. Thanks all.
Hi, I'm Mike Berry. Thanks so much for giving me the opportunity to speak today. I'm going to be talking about leveraging FHIR for immunization information system, bulk data, and data modernization. Next slide. So we've heard today quite a bit already about submitting immunizations to public health. So I presume most of you are familiar with immunization information systems, or IIS, as confidential population-based systems that collect and consolidate immunization data to provide actionable information for clinical and public health decision-making. Next slide. As far as data exchange, IIS offer on the inbound side, HL7 version 2 unsolicited vaccination update messages, VXU messages coming in. And as well as most IIS will also accept flat files, and the typical IIS has an interactive web application that is made available to users as well. On the outbound side, we have an HL7 version 2 interface as well, QBP and RSP messages. So as far as standards-based data exchange is concerned, the typical IIS partner that wants to get data out of the IIS is going to be submitting HL7 V2 QBP RSP messages one by one is how it works. Most IIS also have some flat file interfaces on the outbound side, such as to the CDC data clearinghouse and to payers for HEDIS data and things like that. But again, as far as standards-based data is concerned, it's typically HL7 version 2, as well as some of the interactive web applications offer outbound interfaces. Next slide. So you've heard about FHIR quite a bit already today, especially from Minnesota. And so I don't need to spend a lot of time on this next generation HL7 standard. The key thing here is it's a set of resources and a modern API for accessing them. Two of the applications of FHIR I'll be talking about today are FHIR bulk data, which is a FHIR-based approach for exporting large amounts of data from a FHIR server, not just one-by-one query response, but bulk data, and Smart on FHIR, which is a health applications interface based on FHIR and other open standards. Next slide. So if you're an IIS and you want to take advantage of FHIR, you have to deploy a FHIR server. And generally speaking, there are two types of architectural models for doing this. The first is a FHIR facade, which is basically a FHIR layer in front of the existing IIS. And there's really two ways to do that. What we heard about this from Minnesota. You can do sort of a data translation layer where you have FHIR REST calls that are going to the underlying legacy database or service, but you're not actually standing up native FHIR storage. You sort of have your legacy system operating and you're translating things on the fly. Or you can have an intermediate FHIR server where you're synchronizing native FHIR storage to that underlying legacy database or service. It might be a nightly synchronization, it might be a real-time synchronization, but the idea is that you have your legacy database or service, but that's not the storage that's being directly queried. Instead, you have a native FHIR service that is being directly queried. The other architectural option is to go with a native FHIR server from the start, where the FHIR storage is the operational data store. And this is a good option for some organizations that are looking to deploy FHIR, especially if they if they're starting from scratch. They don't have a legacy database or service, and they're looking to sort of build from the ground up. But your typical IIS, is already has a service that's running, and so the FHIR facade model is a good model for a lot of IIS. Next slide. So why would an IIS want to do this? Well, so generally speaking, some of the advantages of FHIR are that the FHIR APIs are accessible to general purpose developers. In terms, we've heard a lot about staffing. In terms of the developers who could be comfortable accessing or querying a FHIR API versus developers who are comfortable and have experience querying HL7 version 2 APIs, there's a big difference there. And with FHIR, you also get the benefit of modern APIs, modern software, tools, resources, and a lot of support because there's so much momentum behind FHIR. With FHIR bulk query in particular, there are a lot of advantages. The ability to efficiently access up-to-date immunization data for a large number of patients is something that IIS partners have long wanted to do, right? If you are a provider, a healthcare provider, and you have thousands of patients and you want to access the up-to-date immunization status of those patients, today with HL7 version 2, you have to query every single one of them every day if you want the updated data every day. With FHIR, it's much more efficient, right? A FHIR query can say, give me all of my patients' immunization status whose status has changed since the last time I queried. It's much more efficient. The result is an easy to parse bulk data format, in JSON format. Most developers are very familiar with that. And there's a lot of flexibility for different types of use cases. I talked about hospital or provider. You have schools that might want to query the immunization status for all of their 7th graders entering school this year. You have payers that might want to access the COVID status, the COVID immunization status of all of their covered lives, and so on. The other benefit with FHIR bulk query, as with all of FHIR, is you get the ability to take advantage of a modern authentication authorization framework, one that's much more scalable than what we typically see with HL7 version 2 interfaces. Next slide. So I won't go through the workflow in detail, but the bulk fire workflow for IIS, generally speaking, is the client can request a patient or a group of patients, and the IIS can come back and say, I've received your request. I'm going to be working on it. You can come back and check again later, right? So it's an asynchronous workflow, which can be beneficial both for the IIS and for the client. Next slide. Once the IIS is finished creating the bulk export, the client can come back and say, are you finished? And it can say, I'm finished, and it can present the bulk data. And with Fire bulk data, the results come in what's called ND-JSON files. These are new line delimited JSON files. JSON, again, being this format that many developers are very familiar with already. And it's essentially one file per resource, right? So in Fire, we have immunization resources, we have patient resources, and so on. And so those files can be pulled down and parsed. Next slide. So if you're not familiar with Fire and JSON files, just to give you a quick example of what these things look like. So on the left side of this slide, we have a sort of an example of what a test patient might look like in your typical IIS in terms of the immunization history for the patient, right? So along the left-hand side, we have the vaccine groups for this patient, COVID-19, flu, hepatitis B, and so on. Across from left to right, we have the doses that this patient has received. And then on the right-hand column, we have the clinical decision support or the recommendation for the next dose. On the right side, we have the JSON representation of the Fire resources. On the upper right, we have the patient resource. Obviously, this is not all of the detail. This is sort of a summarized or selected parts of the resource. We have the patient's name and birth date and so on. You can see that's what JSON format looks like. On the right-hand side, on the lower right-hand side, we have an immunization resource, and it's the one that happens to be circled in yellow on the left. That's your pneumococcal 15 dose that was given on June 20th, 2022, and you can sort of see how it's represented there on the right with the various attributes about the vaccine coding, when it was recorded, what the manufacturer is, and so on. Next slide. So I'm going to be talking about one particular implementation, the Rhode Island Immunization Information Systems, known as RICARE. Rhode Island opted to go with a Fire facade model and deployed with the Happy Fire server, along with Smart Backend Services Authorization, which is that scalable, modern scalable authorization model I mentioned earlier. With bulk query, the Rhode Island implementation supports predefined groups, such as all 7th graders at a particular school, or all patients associated with a particular provider, or the client can search for and define custom groups. When querying, the Fire resources that can come back include patient, immunization recommendation, which is that clinical decision support column I showed you on a previous slide, as well as immunization evaluation resources, whether or not the dose was valid according to ACIP recommendations. With bulk query, as you can imagine, it's bulk, right? So you can easily download, 1,000, 10,000, up to 100,000 or more patients in the fraction of a time it would take to do individual HL7 version 2 queries for all of those patients. And the server, as you saw from that workflow, has the flexibility to schedule and allocate resources to the query, right? So if the server is very busy, it can tell the client, come back in a little while when the job is done. Next slide. So all of this work was performed as part of the Helios Fire Accelerator for Public Health, which, again, I know you heard a little bit about that from the Minnesota presentation. It's part of the Immunization Integration Program, IIP, and there are multiple initiatives in the Fire Accelerator for Public Health. Aggregate information to public health, making data in public health systems accessible in bulk, which is ours, and align and optimize public health data sharing. So as far as the make data in public health systems accessible in bulk is concerned, the goal here is to leverage bulk Fire to get a uniform process for querying IIS data and to develop implementation guidance and to actually get this going and to do testing. Next slide. And so the Helios accelerator has been very active, right? We have many participants, vendors, HLN, STC, Envision, EHR vendors such as Epic, several state immunization programs, not just Rhode Island, but also Washington, Minnesota, Oregon, and so on. And as well as ARA, the American Immunization Registry Association. We all got together this past January, at the HL7 working group meeting for a connect-a-thon, and a lot of successful bulk fire data exchanges occurred there. And then we got together again this summer at a virtual testing event where we tested additional functionality, such as, I'm sorry, Damon just commented, I'm sorry, he wanted to clarify, oh, I lost that in the chat, that Helios isn't actually part of IIP. I apologize. The IIP worked on bulk query and then Helios selected bulk query. So sorry for that clarification I had to make. In any case, as far as Helios is concerned, we got together in the summer at a Helios virtual event and conducted additional testing with patient match functionality, creating a group resources, adding patients to groups, right? So if you're a hospital and you have a group of patients and you know that they're in the IIS, you don't have to query them every time. You can actually create and maintain a group of patients in the IIS and then have that come back. So, and we also tested that smart backend services authentication, which I had mentioned earlier. Next slide. So now that we have a fire server, what else can we do with it? What you're looking at on the screen here is just a screenshot from a modern web application with a fire backend, right? So the thing about fire servers is that they're not just flexible and accessible for external partners. They are actually very nice application servers for internal applications as well. So if an IIS is looking to modernize its own applications, its web applications that it makes available to providers, its internal applications for data managers and so on, the Fire server is actually a great application server to build a modernization strategy on. Next slide. Behind the scenes, a web application that's using Fire, that's leveraging a Fire server, is actually submitting Fire queries to the Fire server and getting them back and rendering those responses in the web application itself. So it's a modern application infrastructure that leverages that same Fire server that the IIS deployed for bulk data. Right, so the benefits to deploying a Fire server are not just for external partners, but for internal partners as well. Next slide. So as I mentioned, that Fire server for IIS, it can double as an application modernization strategy to replace legacy web applications with modern front ends that communicate with the Fire backend. Right, so in Rhode Island, we've already done this with immunization data entry and update. But there are many other potential uses: immunization display, patient demographics, smart health cards, school forms, and so on. The Smart on Fire apps that you see in the marketplace today, those are the kinds of applications that can leverage a Fire server deployed at an IIS or elsewhere in public health. You have consumer-facing applications, and there's also an opportunity for IIS to IIS communication via the IZ Gateway. Currently, the IZ Gateway is on HL7 version 2, but there's absolutely an opportunity to leverage Fire there as well. Next slide. So I just wanted to thank, of course, the Rhode Island IIS and CDC, Helios, as well as IIP and ARA and HLN's Rhode Island team. Without all of those individuals, all of those teams, none of this would have been possible. If you have any questions, I'd be happy to answer them. Thanks.
Okay, so I guess it's my turn. So my name's Theron Jepson. I work at the Utah Department of Health and Human Services in our Division of Population Health Informatics program. And the information I'm going to share in these slides, I need to give credit to Rochelle Bolton, our Division of Population Informatics Program Manager. She put together most of the information, but was unable to attend today and asked that I present it. So if we can go to the next slide. So I'll start with a little bit of background. Back in April in 2009, there was a little article that was published in the MMWR describing a novel influenza virus. And that subsequently ushered in the 2009 influenza pandemic. While this turned out not to be the greatest pandemic of our generation, we didn't realize that at the time, but the experience of that made an impression upon us, and we spent the next 10 years building data and IT infrastructure within our programs and systems that would prepare us for the next big thing. We didn't realize it would be coming just a decade later. Next slide. Public health has been Public health has a number of systems that are considered core information systems, such as immunization information systems, electronic death registry systems, public health laboratory information systems, and integrated disease surveillance systems. Integrated disease surveillance systems are really the cornerstone for modern and robust public health case surveillance activities. The whole process falls apart without a solid foundation and a solid integrated disease surveillance system. Next slide. Here in Utah, we use a system called EpiTrax, which was developed in-house using agile methodologies for software development. EpiTrax, it is a web-based application for disease surveillance, case management, contact tracing, and investigation activities, including outbreak management. Since our job is to be able to quickly react to changing surveillance needs, our systems must be a balance between structure and flexibility. We have focused on building a highly configurable system with a solid standards-based framework. We very deliberately take the disease agnostic approach to the system development, meaning we don't build solutions for specific diseases. We place high value on a system user configurability, meaning that the users, we set it up so that users with certain privileges are able to manage the system from the UI, and we don't need to be dependent on developers to make minor changes for operational work. At the same time, we've invested in building partnerships within public health, all communicable disease programs at the Utah Department of Health and Human Services, all local health departments, several tribal public health agencies. I think it's 6 out of the 9 that we have in Utah, and Hill Air Force Base, and their public health office. All these entities use the same instance of EpiTrax in Utah. Next slide. We placed a lot of value in clinical interoperability next. Public health reporting is a burden, we get it. To conserve resources within the public health system in Utah and to simplify as much as we could the reporting process for clinical partners, we centralized reporting and having that all coming into the state health department. Clinical reporting for case surveillance, which is primarily electronic laboratory reporting, ELR, or electronic case reporting, ECR, is managed by one program at the Utah Department of Health and Human Services, and the information is made available to our investigators, our epidemiologists, and analysts throughout the state through this one application, EpiTrax. In order to do that, we built a sister application to EpiTrax named EMSA, and that's EMSA, and it stands for Electronic Message Staging Area. EMSA has 2 primary functions. The first is to receive, parse, and translate incoming messages like ELR messages, ECR messages. again, this is where that balance between the structure and flexibility is so important. We realize that no standard is perfect, and even argue that no implementation is perfect. And we want our system to be able to receive and process real data, not perfect data. We're able to accept data that is reasonably close to a standard, and our system is flexible enough to standardize that data for processing into our system. The second primary function of EMSA is to run and translate data through a series of rule sets to determine the final disposition of that data. The EMSA rule sets do the following. They do they person match, determine if electronic messages should update a case or create a new case, determine the public health agency responsible for investigating a disease case, can set investigation case statuses, and ensure that only relevant clinical information is populated within the EpiTrax system for the cases. Next slide. More recently, we've been working to integrate data from other core public health information systems into EpiTrax. We've established FHIR-based interoperability with both of our electronic death registry system and our immunization information system. While investigators have the ability within EpiTrax to query these systems manually, we do regular automated queries of those systems, pull that data into EpiTrax so it gets updated automatically. Next slide. So this has led us to where we're at now. First, we've saved a lot of time with most laboratory results received electronically and processed automatically. We have significantly cut down on the burden of manual data entry, allowing our public health investigators and epidemiologists to focus more on meaningful work that they're hired to do, and not so much the menial task of data entry, such as looking into interventions and evaluations of that work, of the data. With an early ECR pilot project that we did several years ago, we were able to completely eliminate fax reporting of handheld forms for an entire health system that participated in that project, saving hundreds of hours of clinic staff time and eliminating disruptions to clinic flow. The data from our electronic feeds is more timely, it's more complete and accurate, which allows public health to react more real time to public health threats. System integration has made access to additional data sources easier for investigators, and electronic data collection and automation have allowed for novel surveillance practices. For example, a few years back, we were able to increase the identification of acute hepatitis C cases by collecting negative laboratory results electronically. And then using those negative results, we were able to quickly identify seroconverters when we got new results in, comparing those to the negative results that we had received previously. Next slide. So we're not the only public health, let's see, I think you need to go the other way. There we go. We are not the only public health agency that is using EpiTrax and or EMSA. Those jurisdictions that are shaded in the green, they're currently operational with EpiTrax, and several of those also use EMSA in conjunction with EpiTrax. Those jurisdictions that are in the kind of the teal shade are either in the process of adopting or are evaluating and considering the adoption of the EpiTrax system and or EMSA. Next slide. So to enable collaboration of public health agencies utilizing the EpiTrax suite of applications, the EpiTrax Community Consortium was created and it's been in place since 2015. Through the consortium, these jurisdictions work together to design, develop, implement, and maintain EpiTrax. There's no financial obligation to jurisdictions to each other, and there is no requirement that jurisdictions contribute code to the EpiTrax system in order to use the software. However, jurisdictions each individually are responsible for their own hosting and data security of the system. Next slide. So all decision-making power is held by public health jurisdictions. Each of the jurisdictions that participate appoint one person to act as a release manager on behalf of the agency. The release manager has full authority to represent their jurisdiction in all decisions. Release managers are encouraged to have some type of process, a formal process in place to gather input and feedback on proposals from their agency, including the end users of the software. In Utah, the release manager brings decisions to what we have named the Utah Core Team, which is comprised of 3 local health department representatives, 3 state health department representatives. This group provides recommendations to the release manager and may require vetting or some type of additional review to other stakeholders as necessary. Jurisdictional contributors can participate in the consortium activities in a number of different ways. Contributors can propose enhancements, new features, submit bug reports. They can contribute code and review or test code changes and assist with application documentation. In order to contribute code, jurisdictions must sign a contributor license agreement. The Utah Department of Health and Human Services serves as the code steward for EpiTrax and AMSA. In this role, the Utah Department of Health and Human Services manages the different consortium branches and releases of the code, facilitates formal consortium activities, and safeguard the legal integrity of the code base. Next slide. And this is the final slide. Moving forward, some of our goals, we plan to continue to find universal solutions to problems. We want our technology and processes to support any public health surveillance needs and to be able to quickly react to surveillance changes. We're going to continue to encourage support and implement interoperability that is grounded in standards. We are focusing on data quality, deficiencies in timeliness of data, completeness and accuracy of data. These are significant roadblocks to robust and automated surveillance processes. And finally, we place a high value on pilot projects and demonstration projects with a commitment from those involved to follow them through to successful, sustainable real-world implementations. And I guess I'm happy to take any questions when that time comes regarding any information that was presented here.
Thanks so much, really appreciate it. And I think we can move on to Jim's presentation, and then we will have time for questions at the end.
Great, thanks so much. So just before I start, I did want to acknowledge that this is not all work I'm doing by myself. We have a great team here at AWS working on public health, just that I did want to acknowledge, but we can move on to the next slide. Some of the things that we do are really just around strategy development. You know, we find that a lot of health departments are really struggling with how to start their DMI initiatives. And so one of the things that we can actually do for free is come in with our strategy development sessions. And we can move on to the next slide. We actually have a process that's called working backwards. It's a very defined process where we actually have skilled facilitators that helps really pull out your leadership team, as well as the subject matter experts, exactly what you're trying to accomplish, and get it all down into a key deliverable that you can then use to get buy-in from leadership within your department, and also move forward to actually start implementing your strategy. Some of the work we've done, the next slide, has just been with some states, helping them do their overall data modernization strategies. So just more like strategy development. But if we can move on to the next slide, some of the other work that we do is around specific applications as well. One of the first projects that I helped a state do is actually design a new disease surveillance system. And the best way to do that is to really start with really defining what you're trying to accomplish. And for those of you who know the Public Health Informatics Institute and their philosophy of really defining what you're trying to accomplish before you start building it, because that is why a lot of IT projects fail. This process, I think, really ensures that you're going to have a successful project, because we don't even start building until we spend a lot of time actually working through with you to define what it is that you're trying to accomplish. Next slide. So after we do those strategy sessions, some of the things that we can do as well are actually start to implement some proof of concepts to actually show that they work. So we're not like asking you to commit to work with us just because you're doing one of those working backwards sessions, but we will actually help you then implement a proof of concept. And that's the approach that we've taken with some of these other states, and have actually started implementing a new disease surveillance system in Iowa. Next slide. So as health departments think about their strategy, one of the first things that people often think about, and I think one of the things that we did during the pandemic, was what we call lift and shift. During COVID, it was not the time to really rip and replace systems that had been around for 20 plus years and try to find a new system. But those were failing at a great rate. The immunization information systems, the disease surveillance systems that were run on premise were getting hit with data at a level that was just unheard of before. And so during COVID, we really focused on lift and shift. And we can move on to the next slide. And really what that was is actually pulling some of those legacy application off of on-premise and putting that same application in the cloud. So we did that with many different immunization information systems. We did that with many different disease surveillance systems. And we were actually able to help those states get through the pandemic, stabilize, stop having their systems fail. And that lift and shift strategy really worked. But if we can move on to the next slide, now that we've done that, what we're really starting to see coming out of our strategy sessions with public health now is it's time now to really start implementing new cloud native technology. I mean, these systems that we've had in place are great, but we have to admit the fact that they are old. They're running on old technology, and old technology doesn't always translate that well when we move to the cloud. It works, it runs very well, but if we can move to the next slide, just thinking about how we can re-architect some of these systems to be more cloud native gets us in a place where we're going to start seeing a more sustainable solution moving forward. Non-cloud native applications can cost, I think, more money to run in the cloud. But if we start moving to cloud native, that's where we actually start to see those savings, those real cost savings of running applications in the cloud. And we've seen examples of greater than 50% savings of hosting an application when we start moving applications to cloud native. So it's definitely something that's a little scarier to start thinking about than just a lift and shift strategy. But developing new cloud native solutions or looking at existing low code, no code applications that are already cloud native that can meet some of the needs of public health is, I think, something that we're definitely seeing come up in our strategies across different public health departments. And the disease surveillance system that we're helping one customer implement, that is a low code cloud native application. So I think we're going to start seeing some of the successes of that hopefully very soon. So I do want to go over some other kind of specific examples of ways that we're helping public health departments as well, besides our lift and shift and new cloud native development. If we can move on to the next slide. Yeah, so sorry, and the next slide. So one of the other things that I think we're really seeing coming out of our strategy development with public health departments is the need for modern data analytics. And instead of starting with ripping and replacing applications, we're seeing a lot of health departments really start to think about their analytics. And if you think about some of the things that we heard earlier about, creating a fire server for your applications, you can do that with your legacy applications. The same is true with data analytics. We can start pulling data over into data lakes. We have services like Health Lake that can actually start making your data ready for fire. It can be fire-enabled data with our Health Lake. We have tools like AI and ML that can start actually helping you figure out how to analyze your data, doing things like text and translation and image translation and anomaly detection. So we have a lot of really amazing tools for modern data analytics. And we're working with a few customers right now to really start building out that model for what a modern data analytics solution looks like for a public health department. From something simple like pulling your immunization data and disease surveillance data into a data lake and then having SAS or R pointed at that to run on the cloud for your analytics. From simple things like that to much more complex Health Lake implementations to really make your data fire ready. One of the others, and we can go on to the next slide. One of the other solutions that we're working on is actually, you heard about before, the fire bulk query. We've actually built a cloud native solution, kind of taking that approach of putting the facade on top of the data to make it ready for fire. And we put that there so that an immunization information system, really all they have to do is drop their data into a bucket in the cloud, and their data is then ready to be queried by any external partner using fire services. It doesn't hit the resources of their immunization information system. If you think about the resources that it would take an immunization information system to respond to these queries, that could really bring down even the most advanced immunization information systems. So we put all of that processing power in the middle using AI and ML again to help respond to those queries. And so now we've got a fire bulk query for IS that can sit adjacent to your immunization information system. Let's go on to the next slide. One of the other really exciting projects that we have is for genomic sequencing analytics. We heard from several health departments that they were really struggling with building out the infrastructure to actually run genomic sequencing. And that's not just for COVID. There's so many other use cases that are important to have a scalable genomic sequencing infrastructure for a public health department. So we actually worked with Wisconsin Health Department. It's their lab that we were working with, and we've developed a solution that we're calling Easy Genomics that is now going to be a license-free point-and-click interface. You don't have to understand what we call our command line interface to really understand programming. It's a simple point-and-click interface, no licensing associated with it, where you can actually build a scalable genomics sequencing solution in the cloud. So that's one really exciting thing that we've done starting with Wisconsin. And also talking with our friends at APHL about implementing that there as a shared solution for multiple states to take advantage of. Next slide. Another exciting project that we're working on with several states is our intelligent document processing. And no matter who we talk to, no matter how advanced this data is, we find that there is still tons of paper coming in. And it's not a problem that's going to go away immediately, because those are solutions that not only involve updating the technology at the health department, but also updating the technology at the providers. And sometimes that's very challenging. And so we have solutions for intelligent document processing that can use AI and ML, start learning what your forms look like and learning how to pull out, we can go to the next slide, pull out key value pairs from your different forms that are coming in and start sending those to the appropriate system. So that's another really exciting project that we're working on across the country with different use cases like electronic lab reporting, audiology. So I think there are a lot of really great potential use cases for our intelligent document processing. And if we can move on to the next slide, the other kind of interesting technology that it's not something I ever thought I'd be talking about in public health, but it turns out it's really important, is actually having a call center, or really, I'm going to say like a unified communications, a multi-mode, multi-channel communications center where your constituents, whether, as a state health department, your constituents might be providers and local health departments. As a local health department, your constituents might be the public. But having a scalable interface to be able to communicate with your stakeholders is a really critical part of public health, whether that's having a phone tree that you can utilize, having multimodal chat, text, whatever you might need to have available. Our services with Amazon Connect can actually help just build that overnight. It's so easy to configure. You can get that going very quickly. You can have agents answering the phone the next day. You can have people responding to chats. And one of the really amazing things is you can start using the AI and ML with the chat bots as well to start understanding what questions are coming in and start actually answering the questions as well, to start making it easier on the people responding to those questions. And then I did want to throw in on the next slide just one more plug for, I think, a very important part of what we're doing right now, which is we understand that there are parts of cloud technology that are really important for public health professionals to understand, whether you're an informatician or a laboratorian. There are different skill sets that you need to understand about cloud technology that are really different than the skill sets that you might rely on for your central IT department on how to migrate an application for you. But understanding how AI and ML might work, or understanding how some of our analytics tools work, those are the things that we've actually created training pathways for public health professionals. So you can take a picture of this and it will, with your camera, and it will send you directly to our blog about that. I thought that might be easier than putting the link in this particular presentation, but that will actually lead to our cloud training pathways, and I'll put the link in the chat as well. So I think I'll stop there because we wanted to save some time for questions. Thanks, Holly.
Thanks so much. What an excellent set of presentations to close out today. We do have quite a few questions that have come in. So if we could get all three of our presenters back pinned up, that would be excellent. I'll start with the one for you, Jim, since you're still on our screen here. A question in the chat was asking, can communications tools allow you to send out messages to groups of healthcare providers, schools, employees, et cetera, perhaps by a geographical area or region?
Yeah, that's actually a part of our suite of communications tools. That's a great point. It's not just incoming communications, but there's another set of services that we call Pinpoint that allow you to do exactly what you're saying, Heather, to pinpoint those groups that you need to communicate with and send out directed messages to them. And one of the really cool things that we've worked with some health departments and their community-based organizations is for health departments to allow their CBOs to utilize that same infrastructure so that the messaging can come from more trusted sources as well.
Excellent. One other question for you, Jim, while you're off mute. How could public health organizations, folks, programs within departments go about collaboration and strategy sessions with AWS?
Yeah, I'll put my email in the chat as well. All you have to do is reach out
Awesome.
and we'll get it scheduled.
Great, thank you so much. For folks also looking in the Q&A, I'm going a little bit from bottom up here. So For Utah, are you able to share a little bit more about the DMI roadmap for EpiTrax? Specific questions from Chris there was wondering about cloud native and plans for fire.
Can you hear me okay? Yeah, so right now, most of that would be like as far as it being cloud-based, I can't speak to what our future plans are there. If that's been a discussion that's occurred within the EpiTrax consortium. There is a meeting planned for consortium members next week in Las Vegas. And that may be something that they discuss. I'm not participating in those meetings, so I don't know the plan as far as cloud-based. We are, as part of a broader project, to move several of our applications. Now, this is like I mentioned in the presentation, each jurisdiction is responsible for hosting and security of their application. Utah, we're moving ours to AWS, but that's just for our instance. So, I guess as far as cloud-based, I don't know if that's what you're asking about, because that is something that individual jurisdictions can do. And as far as fire-enabled functionality, like I mentioned, we do have some fire connections right now internally in Utah with our immunization system and with our death registry. But as far as connecting to like healthcare providers versus doing versus exclusively doing connections like with ELR reporting or ECR reporting, we haven't, those are probably things that are on the future roadmap, but we haven't got into detailed discussions on where that fits in just yet. Part of it, I think, is looking at where bulk fire takes us.
Excellent, thank you. Relatedly, we also had a question for you about if the EpiTrax was also being used by non-infectious disease EPIs for things like lead, mercury, overdoses, chronic disease, etc.
Yeah, as I mentioned in the presentation, we're trying to make it as much as disease agnostic as possible. We have, I think, one of the first disease conditions that we worked with when we first initiated, or when we first put in or started with ELR reporting, was lead data. So yes, we do have lead, and it is flexible to include others. They may not always use the same workflow. We've even explored possibly using it for chronic disease. We just haven't been able to get that far down the road with those use cases. But yeah, there would be some ability to, I mentioned, the system is really disease agnostic. And as far as the workflows, there can be things set up so that if there is no disease investigation or things like that needed, that an incoming disease report can be set to, what we'd say, like set a state case status, if there's a need for a local jurisdiction case status, and put it to closed and finalized. That's all possible. So there is the option to include more than just infectious disease data. Yes.
Got it. And I think that is a little bit related to another question that came in, wondering if there were ways in EpiTrax to have data that is not necessarily part of ELR or ECR, when you might need additional EHR data elements. So I think the question there is thinking about for things like long COVID, where there might not be existing data elements in a standard report, if there are ways to kind of more flexibly add some additional data elements as needed.
Yeah, so we have the ability to, so there's core data elements that are part of any disease event that is entered into EpiTrax, and adding that data can be done manually. We also have the ability to upload data through the back end. But as far as something that's been introduced into the UI that allows you to upload data specific to the structure of the whatever data is needed for like a disease-specific investigation. That doesn't exist on the front end yet, and I don't know if that's what's being asked, but there is the ability on the back end to, Postgres database that's how we use it, is to upload data that way. But as far as some type of front end tool that allows that, we haven't developed that yet. No.
Excellent, thank you. And Andrea had a great question in here. I think it's a little bit higher level, so maybe anyone on the panel could speak to this. But the question was, has there been any discussion in looking at reporting regulations to update and identify gaps where public health data is needed? So thinking about things like at-home consumer testing, those are not generally reportable, certainly with the exception of COVID during the public health emergency. But curious if that's come up in any conversation or work for any of the three of you, thinking about how we could get some more creative data sources and how they might be able to be integrated into public health systems.
I can just speak a little bit to so like I mentioned in the presentation, we have this sister application, EMSA, and really it goes beyond just that. We've developed we call it our reportal. It's a way but people have to have, we have to know about them ahead of time, and they have to have an account set up and be able to screen by screen either enter in pieces of information for a reportable event individually, or we give them a template and they can, like a CSV flat file, and they can upload line level data that way. That really wouldn't necessarily meet the need that you're talking about, like an individual person wanting to report a home COVID test, but it allows for like labs that may not have the ability to produce an HL7 ELR lab message or report via ECR to still report in a semi-automated way. And that integrates directly, and it comes in through EMSA and then is put in and processed into EpiTracks.
Great, thank you. Jim or Mike, has that come up in any of the work that you all have done thinking about consumer reported information and how that might be able to be integrated?
I actually haven't. I mean, I've heard people talk about that, but it hasn't come up specifically with a project that anyone's wanted to address with us.
Yeah, same on the IIS side. We haven't, that hasn't come up.
Got it. I know patient reported data has started to become more of a hot topic, thinking about wearables, and I'm sure the at-home testing will bring that up even more in the future. Our one last question that we've got in the Q&A, again for Theron, sorry to everyone had Utah questions today, asking about the level of effort and resources required to be able to program EMSA to meet the needs of being able to reconstruct those messages and then ingest into the consuming system.
So as part of the consortium, we can probably provide some technical assistance, but most of the configuration stuff that would be needed can be done through the UI. And of course, it would probably take a little bit of assistance and help to kind of understand the workflow and the different menus and options within EMSA and how to set and configure things up. But that's part of some of the help and assistance that would be provided within the EpiTracks consortium and through that group.
Got it. Thank you. And I think I just saw one last question come in, but now it disappeared. So I'll do my best to try and remember it. But the question, Jim, was for Amazon, thinking about ways that you could work with kind of non-healthcare organizations like payers or community organizations.
Yeah, I think that's a great question. You know, if public health were to build this, would those stakeholders be able to send a Fireball query? And I think there are tools that we could build to make it easy for them to do that. Definitely.
Excellent. In the last 2 minutes, Heather, with a really excellent question for anyone who wants to speak to this. If anyone can speak to platforms that support FHIR's ability to get forms back to providers or patients, so thinking perhaps FHIR questionnaires, if folks have any experience implementing those or any other ideas on that topic.
Yeah, I was just going to say fire questionnaires are the way to do that. We haven't implemented that ourselves, but that is how you would do it. And you know, and when you're thinking about fire servers, and this is sort of related to the previous question, when you're thinking about fire servers in public health and consumer access, you know, you do have to think about the you know, from the consumer's point of view. There are, you know, different states have set up different infrastructure for consumer access, and of course consumers are also accessing fire servers at the provider level. You know, if their provider is running Epic and they're connecting to the fire server there, you'd want to think about from the consumer perspective, you know, how to present a way for the consumer to connect to a public health fire server in a way that's it's not confusing for the consumer. But to go back to the question, yeah, I mean, fire questionnaires are the way you would do that.
Well, that was the most perfect timing. You ended exactly on 3:30. So thanks again so much, everyone. Really appreciated the excellent presentations and the really thoughtful questions and answers. And I think I probably turn this back over to someone else to close us out, but just in case that I don't, we'll be back live tomorrow for another day and some additional presentations. I believe Jim Jurgis will be kicking the day off tomorrow. So we look forward to seeing many of you tomorrow. And if someone after me is taking the mic, please go for it. Thanks again.
Thanks, Molly. I think that's a great closeout. We'll see you all tomorrow. Thanks again.